washed it. Yay, it worked. There we go. You never know. you just never know with technology today. So I'm really glad that worked. Okay, here, hold on. Let me do this. Get set things up. All right, excellent. Well, listen, I hope you're having a good weekend. I hope that your IC is doing well and that you're not in a lot of pain today. But if you are in a lot of pain today, if you find yourself very frustrated and don't really know what to do next, I'm your girl, my friends. I am your girl. Here, I got to open up something on this computer right here. Thankfully, it's already open. Yes, it is. Excellent. Okay, hold on a sec. There we go. Hello, Boria. Nice to see you. So again, we are streaming on Facebook and YouTube. Normally when I do these meetings, I will do them for anywhere from 2 hours to 5 hours. I am here at your pleasure. I am happy to take any questions that you might have about interstitial cystitis, bladder pain, chronic prostatitis. Actually served on the American Urology Association guidelines for men with male pelvic pain. And so I'm quite knowledgeable in that area as well. And you know what? I'm just here for you. Hello, Loretta. Loretta says it's super hot and humid in Pennsylvania. It has been very, very hot here too. We hit 110 a couple of days. We had 110 2 days in a row. Crazy. Oh, look at that. I just got an email from one of our national pelvic pain guys, women. That's fantastic. And a lot of people are really surprised because when it's super hot, you can flare. And when it's super cold, you can flare. Why? Because, there are a couple of different reasons. Number one is just stress. That when you're in periods of very, very intense stress, that tends to sensitize nerves. That then tends to exacerbate some of our pain, can make your pelvic floor muscles tight, et cetera, et cetera. But the real hard challenge when it's hot is dehydration. Because when you get super dehydrated, as I have gotten super dehydrated, I've ended up at the emergency room a couple of times with my heart racing from dehydration. It's really, really important to make sure that you stay hydrated. I forget that I'm older now and I can't, back when I was a kid, if it was 100 degrees, I'd be playing in a tennis tournament and having the time of my life. Now, if it's over 90, I need to be just a little bit on the careful side. So it's just really, really important that you stay hydrated. You got to keep your urine nice and dilute so it's not super irritating to your bladder wall, especially if you have Hunner's lesions or if you have estrogen atrophy, where your bladder wall is really, 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 really vulnerable. Your job is to create an environment that will support healing of your bladder. If you're pelvic floor driven, you're not going to be as diet sensitive. Now, the other question is, what can you drink? What's bladder friendly that you can drink on a hot summer day? I have another website that's called IC Diet Project, the IC Diet Project. Man, we built this 15 years ago. I add to it every month. And this is where we feature recipes for IC patients and different food ideas. And there are some really, really good recipes over there for summer drinks. What I tend to turn to first is coconut water. Coconut water, high in potassium. I tend to trend a little low in potassium. I had a coconut water this big earlier this morning because I was out in the yard doing stuff when it was pretty hot. I will go to a kind of a spa water type of thing where you can do some water with some lemon peel, not lemon juice. Lemon juice is very, very acidic. That can be a problem, but lemon peel has less acid. You still get that flavor. Put some mint leaves in it, put some cucumber in it, put some pear slices in it. You can make yourself a fruit smoothie. You can do a smoothie with ice, with frozen banana, maybe some mango. Mango tends to be a bit more on the icy friendly side. Blueberries. You can make yourself a vanilla shake. You can make yourself an Italian soda. An Italian soda is based on mineral water combined with a little bit of Italian soda flavoring. And of course, we just want you to do an icy friendly flavor. Please don't do lemon. Pick raspberry. Raspberry Italian sodas are fantastic. You know what's a really good really good Italian soda? Coconut. Coconut Italian soda is fabulous. You know how a regular Coke is really dark brown, super, super concentrated? Um, when you make an Italian soda, it's very, very pale. You basically do a shot of flavoring in a big glass of water and ice. So it's never meant to be dark. If it's dark, you're using too much. It's supposed to be a hint of flavor, a blush of flavor. And you know what? When you get used to it, it's really, really, really good. Now, let's just do a sound check. Is the sound okay? Are we doing okay with sound both on Facebook and on YouTube? I always have to move the microphone closer to my mouth. Noreen says, I see. What did she just say? Loretta says she finds any extremes in temperatures can be problematic. Peggy says sound is good. Sound is good on Facebook. Boria says she can't stand Boria, honey. Girl, this meeting is for you. Because when you're feeling that frustrated, when therapies aren't working for you, what do our guidelines say? Our guidelines say, I wonder if we missed something. We don't want you to keep doing something that isn't working. We want to find the underlying problem and fix the underlying problem. And as Dr. Jerome Weiss says in his book, and as I say in the new book that I'm writing, Western medicine really fails the typical IC patient and pelvic pain patients because doctors stay in their sandbox. Urologist, if you go to a urologist, they're going to assume that it's something related to your urinary tract. You go to a gynecologist, they're going to assume that it's something related to your reproductive tract. You go to a gastroenterologist, it's gut. They don't look at connections. And here's the harsh reality of the pelvis. It's a small confined area with a lot of stuff happening and nothing operates in isolation. Okay, I got a weird thing at the top of my head. I got to fix that. Is that fixed? Okay. Okay, nothing operates in isolation in the pelvis. Everything influences everything. And what a lot of doctors miss are muscles and nerves. But they can do other things too. All right, Sherry says there's an echo. Sherry, do you still have the echo now? Does anybody else have an echo? We've had that happen before with this. Okay, Noreen does not have an echo. Sherry has an echo. Sherry, why don't you reboot? Because if nobody else has the echo, Robbie doesn't have the echo either. So that's you. That's something on your end. Okay. Okay. I would just kind of log in again. Okay, my friends, listen. Y'all know from last week that I've been working on a brand new book on bladder pain, bladder and pelvic pain. And I'm loving it because I am, the last time we wrote an IC pain guide was like 15 years ago. And boy, have we learned a lot in the last 15 years. And so the purpose of this guide is to help you understand the many different things that can cause bladder pain and pelvic pain and what their triggers are, how to differentiate between bladder pain, muscle pain, nerve pain, et cetera, et cetera. And of course, we do that. One of the ways we do that is with phenotyping. And Anne, hold that thought, honey. We do that with phenotyping. We want to try to figure out which group you're in. And so I've gone over the phenotypes in these meetings extensively. We've got Hunner's lesions, bladder wall-driven estrogen atrophy, bladder wall-driven chemical injury, pelvic floor-driven, which is 87% of IC patients, pudendal neuralgia, and of course, widespread pain. Okay, Robbie now says there might be a little bit of an echo. You guys tell me. I can turn off this mic and go to another mic, or I can restart it on Facebook if you want. Okay, but I kind of need to know now before I get into it a little bit more. Boria, sound is good for you, right? On YouTube? I wonder if it's just maybe these microphones are too close. Could that be it? I'll move this one kind of back here, move this one. Testing 1, 2, 3. Gina says it's good on Facebook. All right, it's good on Facebook. Okay, so let's get to Boria for a moment, because Boria's having a really, really, really hard time. And it's so interesting when patients call my office and we start doing, what we would consider a coaching, or you can just call and ask questions. That's fine, either or. And finding the underlying cause of your pain is actually really difficult. Because, and I can't tell you the number of patients who say, well, Jill, it hurts down there. It's just, come on, it's just down there. And I'm like, nah, that's not good enough. I need more information than that. Because my job when I'm talking with you is to try to visualize your anatomy, to try to understand what your anatomy is a little bit more. So I have used for many, many years now, a series of 10 questions that can help identify the source of your pain. Because yes, I know it feels like your bladder. It feels like a bladder infection for all of us. I mean, but in most cases, it's really not. And these questions will help. So what we're going to do is we're going to go over these questions. And I want you to think about your pain and your discomfort as we go over them, okay? So the first one is kind of silly, but you'd be amazed at the number of patients who go, oh, I never thought of it this way. So question number 1, is the pain external or internal? Is it on the outside of your body where you can touch it with your finger, or is it on the inside of your body? And again, it's amazing the number of patients you've been diagnosed with IC. Man, you are thinking bladder infection this whole time, right? And yet, when I ask you that question, the number of patients who say, oh, it's kind of on my vulva. Okay, that is a really important distinction. So, do you have any pain on your skin? Is there any pain on the outside of your body, especially in the crotch area? Where is it? Is it on the left side? Is it on the right side? Is it near the front? Is it near the back? Can you put your finger on it? Can you put your finger on where the pain is? External pain, particularly pain on the vulva, could be signs of estrogen atrophy, fungal infection, or a skin disorder. This is not bladder pain. Now, men can have pain along the penis, along the underneath of their penis, or at the tip of their penis and in the urethra itself. This too could also be skin irritation, but for men, in some cases, it's referred pain from deeper within the pelvis. So again, especially if you're a woman, if you got pain on the vulva, that's not your bladder. 100% not your bladder. In all likelihood, that is estrogen atrophy, something related to estrogen atrophy. Although if you have this is crazy, but doctors know to look for this now. If you have a redness the shape of a menstrual pad, that could be irritation from the menstrual pad. That's happened to me before. There was something I used to wear. What were the pads I used to wear? What's the brand? Very, very popular brand. And they changed it. And I used it And I immediately had irritation and burning. And it was exactly in the shape of the menstrual pad. And then when I smelled the pad, it smelled like glue. And I smelled the box. I just opened up a brand new box, and the whole box smelled like glue. And I just took it back to the store and got a refund. I was like, okay, these were definitely mismade. Okay, so question number one, external pain or internal pain? Okay, if it's internal pain, I want to know where. And again, you're going to be really amazed at the number of patients who say, oh, I never thought of it that way. So, number one, is it bladder pain? So, do you have pain as the bladder fills with urine that is relieved by urination? That points very directly to the bladder wall as a source of pain. So, if you have an injured bladder wall, and urine fills it, urine finds the injury, goes into the injury, hurts like hell, but as soon as you empty your bladder, you feel better. That tells us we're dealing with something related to the bladder wall. Okay, but what about urethral pain? Do you have pain in your urethra? Now, urethra pain, so the urethra is a tube that drains urine from the bladder outside of your body. But urethra pain tends to be very sharp, sudden, and also really strangely random. Like you could just be sitting eating dinner and then bam, you get this sharp burning pain, but it's sharp, it's fast in the urethra. Sometimes you can feel like there's a drop of urine stuck in your urethra that's not coming out. So if you're experiencing the sudden unexpected sharpness in your urethra, or if it's hurting and burning as your urethra is passing through it, that's again not usually IC. That's often related to a UTI, but it can also be related to estrogen atrophy or dryness. And sometimes the dryness is so severe, the atrophy is so severe, a woman develops something called a caruncle. And a caruncle is where the urethra basically slides out. So all of a sudden, you've got a little knob of red, meaty tissue right at the entrance to your urethra that's very, very, very tender to touch. That's usually severe estrogen atrophy in the urethra. You can also have urethral syndrome, and urethral syndrome is just basically an irritated urethra, and they don't really know why, but we really look for a couple of very common things like chemical injury. Could be a sensitivity to a spermicide. It could be a sensitivity to a fabric softener, laundry detergent, could be a sensitivity to a douche or anything at all like that. Okay. Both men and women can struggle with urethral syndrome, often caused by chemicals, including spermicides and soaps. And here's another interesting one. If when you try to release urine, your stream is very narrow, like you're trying to pee through a needle, that's what we call a urethral stricture, and that's often caused by very, very tight muscles. So again, if you have pain in the urethra, not related to your bladder, that's not a sign generally of any sort of bladder disease, except in the case of UTI. That's one of the big differentiating factors between IC and UTI. IC in general doesn't normally cause urethral pain. UTIs do. Estrogen atrophy, though, can cause urethral pain. Okay, another source of pain. Do you have rectal pain? Rectal pain is often associated with hemorrhoids, straining, IBS, and inflammatory bowel disease. So if you're passing hard rock-like stools, this is often the result of not eating enough fiber or maybe drinking enough water. If you have to strain to push stool out, that could mean that you're dealing with very tight muscles or maybe even a rectocele. if you're struggling with sudden moments of painful diarrhea, or if you find yourself struggling with diarrhea and then constipation, and then diarrhea and then constipation, that's irritable bowel syndrome. And anytime you're having funky symptoms around your rectum, especially if you notice any blood at all, that's always a call to your doctor. We just want to kind of get that checked out a little bit. Okay. And you guys hold tight on your questions. I'm just going through my little pain blurb right now. Okay, here's another thing about your pain. Are you having any vaginal pain? You would be amazed at the number of women who have bladder pain, but then when I ask, do you have vaginal pain? They go, oh, yeah, I do. Okay, so they're not always related. They're rarely related. So vaginal pain is actually incredibly common in women who have IC. It can feel like an infection, and yet fungus and or bacteria is usually not found or may not be found. And the first suspect is going to be estrogen atrophy, which occurs as estrogen levels decline, or bacterial vaginosis, especially if if you're older and you have atrophy. But it can also happen with tight pelvic floor muscles. And there are other things that can cause vaginal pain too, like fibroids, endometriosis, STDs, herpes, et cetera, et cetera. So of course, if you're a woman, you got to go have a complete gynecological exam. You know, you'd be amazed at the number of fibroids out there that are embedded in the uterine wall that are pushing on the bladder that are causing some symptoms. It's worth having a gynecological exam. Okay, what about low back pain? Are you having any low back pain? Low back pain is not coming from the bladder. It's usually coming from tight psoas muscles, and or if it's a really sharp low back pain, could be a kidney stone. Okay, what about tailbone pain, coccyx pain? Do you have any of that? Do you have pain when you sit down? Tailbone injuries are very common in IC patients. If you have pain when you sit down, you sit on a bicycle, motorcycle, horse, or if you ride a desk for a long period of time, coccyx injuries are easily missed by urologists and gynecologists who assume symptoms are from the bladder and the urinary tract. What makes these injuries complex are all of the muscles that attach to the tailbone. Thus, if the tailbone is broken or traumatized, so too are the related muscles and nerves. If you consistently have pain when you sit down, you'll want to investigate the health of your tailbone, especially if you have broken it. Tailbone injuries or tailbones can heal out of position and cause widespread muscle and nerve dysfunction. Okay, so that's just question number 2 when I do my coaching is where's the pain on the inside of your body? Okay, let's go to the next question. Question number 3, where is the pain local? Where are you feeling the pain the most? Is it centered in your pelvis, or is it to the left or right of center? Is it on one side, both sides, or is it in the center? You'd be amazed at the number of patients who say it's over my left hip bone. And my immediate answer is, well, that's not your bladder because your bladder is not by your left hip bone. So if you say your pain is centered right by your pubic bone, that's pointing directly to your bladder. But if you've got pain just on one side, or you've got pain far to the left or far to the right, or let's just say in your glute muscles, not your bladder, we're looking at pelvic floor. Pelvic floor, maybe even a joint issue. Okay, here's another question that can help reveal the source of your pelvic pain, and that is, when is the pain the worst? Before you urinate, when your bladder's really full, while you're urinating, or after you're done urinating? When is your pain the worst? Before, during, or after? If your pain is worse when your bladder's really, really full and you feel better when you empty, that points to the bladder wall. If your pain is worse while you're peeing, that really points more to UTI. That could also be estrogen atrophy in the urethra, maybe maybe an infection of the periurethral gland, or for men, maybe benign prostate hyperplasia. And if your pain is worse after you're done peeing, my friends, that points directly to your pelvic floor. Okay. And so I'm going to say it's 50-50. I would say half the people I work with have pain afterwards. And they don't notice their pain getting worse when their bladder gets fuller and fuller. They dread urinating because they know it's going to be worse after they're done. Again, that's a sign of the pelvic floor. Okay. Give me some of your triggers. Jamie, hold that thought. Let me just go through this and I'm going to come back and handle all your questions, okay? Another thing that's going to reveal the source of your pain are your triggers. So if you're flaring from food, okay, that's telling us there's a problem with your bladder wall. Bladder wall pain tends to be very sharp and shrill. It's characterized by being relentless and difficult to ignore. It pounds away at you. It is impossible to concentrate on other things when your bladder is screaming at you. Okay, but is your pain triggered when you're driving or traveling? That's pelvic floor pain. Even though you're peeing a lot, that's still originating from the pelvic floor, most likely. If you have pain with intimacy, and yes, it feels like it's your bladder and you've got to go pee, but that's really a pelvic floor flare. Remember, 87% of IC patients have tight pelvic floor muscles. Does your pain get worse when you're sitting for a long period of time? That's not your bladder. That's your pelvic floor. Does your pain get worse when your hormones are changing? Are you having a flare the day that you ovulate? Are you having a flare a day or two before your period? Okay, that's bringing us back to the bladder wall. And does stress trigger a flare? If stress triggers a flare, we're looking at your nervous system and your muscles. Okay, let's go to our next question. There's only 4 more, and then I know you have a lot of questions, so I promise you we'll get back to those. What does the pain feel like? Is it sharp? Is it dull? Is it achy? Does it burn? Do you feel pressure? Or do you feel like you're being shocked? Is it electrical? So, sharp pain points us to the bladder wall. Dull, achy pain points us to the pelvic floor. Burning absolutely points us to the pelvic floor because a muscle that's working hard is a muscle that builds up lactic acid, and that causes burning in the muscles of the pelvis. Does it feel like pressure? Now, pressure is a really hard symptom to define. I, for one, can say that I don't think I've ever felt pressure down there. I felt pressure when I had a gallbladder attack because something was blocked, but I've never personally felt pressure in my pelvis. I think that some people's brain interprets pressure as pain, but we also would want to look at, is there anything pushing on anything? Could we be dealing with a fibroid tumor pushing on the bladder? Could we be dealing with extreme constipation? Something where something is kind of building up and causing a pressure-like sensation. That's the hardest one. And of course, if you have any electrical symptoms, shocking, that's nerves. That's not your bladder. That's something affecting nerves. I have got some patients, I kid you not, when they flare, their muscles get so tight, they shut nerves down and their feet go numb. Like they will have trouble walking because their muscles are so incredibly tight and squeezing critical nerves up in the pelvis. So again, sharp pain, bladder. achy pain, dull pain, burning pain, muscle, electrical pain. We're dealing with nerves. Okay, let's go to our next question. Question number 7. How long does the pain normally last? Is it just a few minutes? Is it less than a day? Or does it go on for several days, several weeks, or several months, or it never stops? It never stopped for an entire year. My first year when I was diagnosed. I suffered so much that first year. So pain that lasts just a few minutes usually reflects a momentary nerve sensation or perhaps something like sudden urethral pain. Pain that lasts a few hours could easily be the result of a food irritating the bladder wall or maybe some momentary muscle tension. Pain that lasts longer suggests that either the bladder or the muscles or the nerves are stressed and or injured. And we often see this in patients who refuse to modify their diets. Pain that never stops is very concerning, and you've got to talk to your doctor about it for sure. Untreated Hunner's lesions are probably the number one cause of intense pain over time. And there's nothing more heartbreaking than working with a patient who 10 years ago was diagnosed with a Hunner's lesion. They were never treated for it. So they've had an open wound in their bladder for a decade, and then of course the doctor puts them on antidepressants and antihistamines and maybe other medications like that. But none of those fix the fact that we've got a big giant open wound in the bladder that urine is irritating on a daily basis. That's why lesion-specific treatment is so incredibly important. Okay, question number 8. Do certain body positions make your pain worse? Does your pain get worse when you sit down, when you squat, or even when you lay on your back? I went through a period of time where I couldn't lay on my back. Okay, if you have pain when you sit, squat, bend over, and if you can relieve that pain by moving into a new position like standing or rolling onto the other side, this points again to muscles and nerves, not your bladder. Okay, our next question. What helps to reduce the pain, heat or ice? Do you crave heat? And does heat and a heating pad make you feel better? That points us to muscles because heat relaxes muscles. Or do you crave ice? Does ice make you feel better? If it does, that tells us that nerves are involved because ice calms nerves down. So that's another way to try to differentiate what's driving some of your pain. And then the last question is really my favorite question. It's absolutely my favorite question. Is your pain always in the same spot? Like it's always on the left side right there. No matter what happens, it's always right there. If your pain is always in the same location every single time, then we need to know what's at that location. And that's the question you're going to be asking your doctor. It's like, okay, doc, listen. Okay, like for me, I had pain, sharp nerve pain, an inch to the left of my rectum. I still have that today. That is a nerve entrapment. That is a nerve injury from me sitting too long with a tailbone injury. But getting the doctor to listen is a hard thing. And so you just kind of have to pound away at it and say, every single time, doctor, it's right here. It's right on the left side, right in this location. Can you help me understand what's at that location? It could be scar tissue. It could be a muscle injury. It could be maybe a damaged ligament. If it's in the bladder, but let's just say it's slightly to the left in the bladder, slightly to the right of the bladder, then we want the doctor to look at that location, during a cystoscopy to see if there's anything funky at that location. So for example, I had a lady call me who, okay. I think she'd had a hysterectomy. And She'd had a hysterectomy, and then after the hysterectomy, this very specific kind of sharp pain in her bladder always happened in one location. And again, doctors tend to kind of blow us off. They don't have a lot of time. It's like, Jill, it must be all in your head. Or God forbid, they say, honey, you just had surgery. You're just recovering from surgery. You got to give it time. Well, she finally got the doctor to look in her bladder. And you know what they found was a stitch. A stitch. They had perforated her bladder with a stitch. And so when they pulled it out, the pain went away entirely. So again, if the pain is localized to a very specific area, that we're going to do that. So anyway, those are some of the questions that I use when I'm doing coaching with patients to help you differentiate between bladder wall, pelvic floor, nerve. And Boria was saying here when we started the meeting, she can't stand it anymore. So Boria, I want you to call me this week. I mean, you've got my phone number. We have an 800 number. It's right at the top of our website, icnetwork.org. And let me go through some of these questions with you. Maybe we can find something that you can ask your doctor about that the doctor may have missed. Because again, pelvic pain is very complex. There are different groups, and our job is to try to figure out what patient group you're in or what patient phenotype you're in. Okay. Let me go to some of your questions here. Anne says, my friend is suffering nonstop with Klebsiella. Any thoughts? It will not leave her. We had a patient who, I don't know, about 2 months ago, same thing. And they were just really, really struggling. They did a lot of antibiotics and they just weren't killing that sucker. It turned out that lactoferrin helped to boost the immune system to fight off Klebsiella. And that was the only suggestion I had to her, other than doing that next generation DNA urine test to find out what the drug resistances are for that specific Klebsiella infection. Laura says, thank you for everything. Experiencing a little levator ani, working again, getting divorced. Will never forget you calling me. You saved me. God bless. Oh, thank you, Laura. Anytime. I mean, this is what I do, guys. I work 6 days a week. And the thing is I love my job. I love it. I'm happy to do it. And yeah. You guys, I operate under a first come, first serve every day. So if you call and I answer, you're good to go. If you call and I text back, I can't talk right now, or can I call you later? It means I'm already working with somebody. I will call you back. I promise you I will. I give you permission to be a squeaky wheel. Feel free to call me back several times if you need to. Okay. Noreen says, do not be afraid of trying new foods. There are so many lists and all that different. Yeah. This is why we have our new food app. And let me give you an update on the app. It's called the IC101 food app. And we are building it now. We're going through the review process with the Google Play Store. Oh my God. It is so difficult. Google Play is so demanding. We've already had to redo it like 5 times. But let me see if I can show it to you. And I had to buy a new Google iPad to test it. All right, hold on a sec. Let me see if it will be easier for me to show you the food app here. So here, hold on a sec. I gotta change up my. Okay, so it's a watermelon, right? You can see the watermelon. Okay, there you go. The IC101 food app. And it starts with categories like fruits and veg, grains, breads and pastries, dairy, meats, beverages, snacks, sweets, spices, condiments, food additives, vitamins, and supplements. Then when you click on the category, it's an alphabetized list of foods. So you can click on apples and it will tell you the bladder-friendly apples, the triad apples, and the caution apples. Here, hold on a sec. If I go to dairy, and I'm sorry, I have to show it at an angle here. It's really hard to demo these live. You can go to the cheese area, the bladder-friendly cheeses or mozzarella, mild cheddar, feta, ricotta, string cheeses, and American. Cheese to avoid, processed, heavily spiced, cheese, and canned products. All right. There is a fantastic search area. So you can just type in what you want and it will show you everything on that topic, from butter to coffee or whatever. But what makes this very, very different is we now have an AI section where you can ask a question. And the answers are, this is not web-based answers. These are answers from our website. I mean, these are answers from our books. So this is really high quality, verified diet information, not only from research studies, but from 30 years of experience. So it says, hi, I'm your IC 101 food assistant. Ask me anything about bladder-friendly foods, what to avoid, or dietary tips for IC. All right. And so that's currently available right now on the Apple Store. It is in process on the Android Store. Thankfully, I have a very, very patient programmer who's helping us work through these weird random demands that we have. So hopefully it will be there this week. And to the people who volunteered to test it, just know that I bought a pad, so I'm testing it now. I didn't, so when it's listed, I'll probably send you a free link so you can get it. All right. Now let me just say this, not to be controversial, but there are certain personalities online who like to say that diet doesn't matter, or that people emphasize diet too much. And there are a lot of people who have a lot of very different viewpoints, and that's okay. People are entitled to have their own opinions. There's nothing wrong with that. The app that we have is just like our list from 25 years ago. The purpose of our list is to show you what you can eat with confidence. For those of you who are food sensitive, not everybody's food sensitive. It depends upon your phenotype. So you got Hunner's lesions, I can damn well guarantee you are diet sensitive. Diet modification is the most important for patients who have open wounds in their bladder. And that app will help you when you're going shopping, when you're going out to a restaurant, 100%. I have full confidence in that. If you have estrogen atrophy, you are going to be food sensitive. If you have chemocystitis, a chemical injury to your bladder, you're going to be food sensitive until your bladder has a chance to heal. If you've got pelvic floor dysfunction, odds are you might not be as food sensitive. Might be a little food sensitive because you're in a state of ischemia. But once your muscles are relaxed and blood flow gets restored to your bladder is going to heal well, and most of that diet sensitivity should go away. I am pelvic floor patient. What am I drinking today? Lemonade. Listen, I didn't drink lemonade for 30 freaking years out of terror that I would trigger a flare. And it was only COVID that gave me such a horrible cough. The only thing I could think of was hot lemonade with honey. And I was shocked when I drank some. I was perfectly willing to risk the flare just to get the COVID cough to stop. I felt like I was coughing my guts up. It was so bad. And I was shocked that I didn't flare from it at all. Why? Well, I've always had a healthy bladder. There's nothing physically wrong with my bladder, despite the fact that I was peeing every 15 minutes in what I thought was terrible bladder pain. I am a pelvic floor patient, 100%. And I am a widespread pain patient, but my pain does not come from my bladder wall now. And so now that I've got good blood supply going in my bladder, to my bladder, because I've gotten these muscles relaxed and normalized, all of my food sensitivities have gone away. If you have widespread pain, that means we're dealing with an injured central nervous system. We have to avoid caffeine, anything that's neurostimulatory. So that's going to be chocolate, caffeine, things like that. So the purpose of the diet is to just give you some confidence. I mean, our food app is to give you some confidence so that you can go out and try new things. It's not, and honestly, there is a very small group of people who are down to eating like 5 safe foods, and those are the really severe Hunner's lesion patients. And we need to help that. Lesion-specific therapies can help. Kayleen said, I just took a long walk with Otis. Excellent. Love it. I hurt my foot. I cannot do a walk right now. I've reactivated an old tennis injury, so I'm having trouble walking on my left foot. So I went to the gym this morning and I lifted weights. I did my core workout. Estelle said, do people suffer from constipation with IC? If your IC is coming from tight pelvic floor muscles, that answer is yes, for sure. If you have widespread pain, you have IC, IBS, then it also could be IBS-driven constipation. So the big answer is yes. And what almost every IC patient can attest to is that when you're super concentrated, you're going to be a lot more uncomfortable. And that's just because if your rectum and your lower bowel, lower intestine is filled with stool that's not coming out, it's just going to start pushing on things, and that's going to be very uncomfortable. Very, very uncomfortable. Not to be gross, but I'm just going to be gross for a moment. No shame. We can talk about anything here. There is a condition called packing. And what that means is that you basically have a lot of small little poops that just accumulate in your rectum, but they're so small you can't really push them out. And so, I mean, they're just kind of stuck there, and then you got more and more and more and more and more, and before you know it, your rectum is now filled with these little rocks. And releasing these little rocks can be quite challenging. You got to remember, a normal bowel movement, your stool looks like a long S shape, a long flexible sausage. It's not supposed to be in little pieces, little hard pieces. If it is in little hard pieces, you're probably not drinking enough water and or eating enough fiber. Remember, for a woman, you need to have 20 to 25 grams of fiber a day. For a man, 25 to 30 grams of fiber a day to support those normal bowel movements. And it's so, speaking as somebody who had IBS horrifically in my 20s and a lot of bowel pain, it is so lovely to actually have pain-free bowel movements. You know what I mean. Jamie said, just confirming, I thought I heard you say that estrogen-driven atrophy is a cause of IC. I've been on vaginal estrogen for years, but had my first flare in December. It seems to be very diet-driven, no urgency or relief after voiding issues. What phenotype would that be? That is bladder wall-driven estrogen atrophy, Jamie. Your bladder needs estrogen to make mucus. When you're getting older or you're on estrogen suppression medication, Lupron for endo, birth control, or estrogen suppression for cancer, you're entering menopause. And unfortunately, your bladder needs estrogen to make that nice, thick coating of mucus. And when you don't have the estrogen, you don't have the mucus, which means your bladder's ability to defend itself is now compromised. And that cup of coffee you had every day in your 40s, all of a sudden in your 50s triggers pain. And it's triggering pain because your bladder just doesn't have that normal mucosal layer that protects it. We call that the genitourinary syndrome of menopause. Kim says, when you try and cannot urinate, terrible pain after self-catheterization to urinate. So Kim, if you're having trouble urinating, we're going to look for a couple of different things. The first thing we're going to look for is, are your muscles super, super, super tight? Have you ever noticed that when you have an attack of diarrhea, if you're an IBS patient and you've eaten the wrong thing and you're sitting on the toilet having those horrific bowel spasms, which I had for many, many years, you realize that you can't pee for about 10 to 15 minutes. You want to pee, but you can't pee because those muscles are really tight from the diarrhea. And you have to wait until the muscles relax to release urine. So concept number one, are we dealing with tight muscles? And then concept number two, Kim, is are we dealing with nerves and nerves that might be damaged? If you're unable to urinate and you cannot release urine from your bladder, that is considered a medical emergency, and that is a trip to the emergency room or urgent care at a minimum. If you have to self-catheterize to release urine, then, I mean, I was working with a gentleman this week who's been doing that for years. Like, that kind of brings a couple of different things to mind. Kind of concept number one is his bladder so badly compromised that any urine in there hurts like hell, so he just wants to get the urine out as quickly as he can? Or are we dealing with kind of just funky nerves, nerves that just aren't allowing him to urinate for one reason or another? And with the Klebsiella, I would consider lactoferrin. Here, hold on a sec. Sherry says, if I don't relieve myself on time and wait too late to pee, it's a trigger. It can be, sure. I was working out in the yard this morning for about 2 hours setting up irrigation, and my bladder got really, really full. And I'm like, I get a little bit more. And then all of a sudden I started to feel a little bit of urine moving into my urethra. And I went, okay, got to go to the bathroom. The joys of getting older. Kim says, caffeine, fructose, sugar are triggers to stop the ability to urinate or to have a BM. Too much pain with sex, so it's out of question. Okay, so Kim, so the pain with intimacy, in all likelihood, is related to muscles. If you're saying that caffeine, fructose, and sugar stop you from being able to empty your bladder, is it the pain that's stopping you from emptying your bladder? That would be really unusual. Noreen said, do I have this right? The IC food app. It's the IC 101 food app. Brandon says, hey, Brandon, how you doing, dude? Thanks for talking with me on the phone when I was in terrible distress about my horrible experience in another support group. You know what? Thanks for bringing that up. I'm just going to be really bold, and I'm going to say right now that I think that the internet groups, the social media IC groups, are absolutely at their worst. I went in and I went through and did a kind of deep dive and went and visited a whole bunch of groups to just kind of look at what they were doing. And I just couldn't believe what I was reading. I couldn't believe it. There were patients who were in desperate need of help, who were being ignored. There were patients who were suicidal, who were being ignored. Group leaders were not stepping in and doing their job. There was horrific advice being given from one patient to another. Here, the fundamental flaw with groups online, and you got to understand, I started the first groups online. Okay, 33 years ago. Yes, it was me. I built the first urology support groups on America Online and on CompuServe. I built the first website on IC. I built the first support forum IC on IC. But back then, the internet was a nice place. It was educational. It was encouraging. We didn't descend into fights and name calling back then. You could come into, especially before social media, we had a forum where I trained 20 volunteers. And our number one job was to give you a place where you could talk and vent, but it was also to protect you. So we caught a lot of salespeople pretending to be patients coming in and saying crazy things like, hey, I bought this magnet that I put under my bed and this cured me. Turned out that was a sales rep for the magnet company. And for 20 years or 15, 18 years, the IC network was the only online support out there. And we had 200,000 patients a month using us. It was great. It was a hard work, 24 hours a day. We had Diane, we had Donna, we had a whole team of moderators. It was the place where people came because it was safe. I worked really hard to keep it safe. And if people acted out and said really rude things, we had a talking to. I didn't let it fly. And if people said crazy things, I would ban them. And believe me, that it didn't happen a lot, but it did happen. But once social media came along, a lot of other people started groups without a lot of training. And more importantly, groups have become a place where people attack each other. One of the rules for our forum was patients in pain may say something that they really don't intend. Patients, or they may hear something that was not intended. So we had a very active group of moderators who stepped in really, really quickly when there was any sort of dispute. Man, we nipped that in the bud. We made sure everybody was okay. That's not happening now. And I cannot, even the group that I thought was the best group online, I was just horrified by what I was reading. And I cannot in good conscience recommend any of the online support groups right now. And the fundamental problem is you can't put apples, oranges, and bananas in the same group and expect it to help. We have come so far now. We have phenotyping now. So the fundamental problem, if you ran a support group like I did for many years, you learn really quickly that there's two distinct patients. There's a newbie and there's a grizzled veteran. The newbie is somebody newly diagnosed. They need hope, comfort, and encouragement. The grizzled veteran is somebody who's really struggled for a long time. They need a place to vent. They need a place to yell, to scream, to learn. You can't put newbies and veterans in the same group. The veterans scare the newbies like nobody's business, and that newbie walked out crying. So when I ran my support group, newbies always came first. We opened the floor to newbies, and then when the newbies did their thing, we let the grizzled veterans go, but I always made sure everybody had context. That doesn't happen online anymore. But more importantly, a Hunner's lesion patient should not be given advice to somebody with pelvic floor tension. Somebody with pudendal neuralgia is not going to get any benefit from talking with somebody who has estrogen atrophy. And so here we now have this fantastic process where you can put discussions into context, phenotyping. I mean, there needs to be a Hunner's lesion group. There needs to be an estrogen atrophy group. There needs to be a pelvic floor group. There needs to be a widespread pain group. So y'all can be in the right group, talking to the right people, asking the right questions, getting the right answers from the people who understand what you're going through. And I'm, we have to listen. Support group leaders burn out very, very quickly. You want to talk about the least recognized volunteer activity is be a support group leader. Man, they work their butt off for 5 years. Very, very, very few thank yous, and they walk away. I mean, I'm a rarity doing this for 33 years. Most people don't do it that long, but I can take it, But I think some of the people who started some of the original groups online, they're burnt out. They're just not participating. They're just letting it go into the wild. And I think that patients are genuinely being hurt. I really do. I call social media poison. I genuinely believe it's poisonous now. And so people are saying, yeah, but you're on social media right now. Yeah, you know what? The reason why I do this support group on Facebook and on YouTube is so that there's one group run by a seasoned, trained group leader, but I don't come back and spend a lot of personal time on Facebook. I have other things I want to do, like writing books. And it makes me crazy. Noreen said, is having anxiety with IC a long-time problem? Absolutely. If you've got anxiety disorder, odds are you're probably in the widespread pain phenotype. So if you have IC, IBS, vulvodynia, TMJ, migraines, any two of those, there are fibromyalgia, many more, combined with anxiety, very sensitive skin, wicked sense of smell. What that means is we're dealing with a central nervous system injury. That's the widespread pain phenotype. And anxiety, it's a huge part of that. I have had anxiety disorder since I was attacked when I was in 4th grade. And I have good days and bad days, good days and bad days. Well, mostly good days now because I completely understand what it is and I've got really good self-help skills. But I spent, one of the things that I struggle with is driving long distances by myself. I don't like to do that. That goes back to when we didn't have phones and cars. My cars used to break down all the time. But also where I am in California, a lot of women have been driving alone were murdered. And I witnessed that myself growing up. And so I've never felt particularly comfortable driving by myself a long distance. And yet yesterday I drove about 50 miles. I go out and practice. But I'm anxious when I'm doing it. So I put on some really good music and I just go for it. It's like, Jill, you got it. You got to spread your wings. Allison said, may I ask if anyone taking Elmeron suffers from frequent migraine, visual disturbances, and migraine headaches? I've taken it since November. Honey, Allison, why are you taking Elmeron? Elmeron is associated with retinal problems. If you're already having visual disturbances, and you've only been on it since November, and research shows that some people's eyes change in that first year, man, that's a big sign that you got to go get your eyes checked. This may not be the right medication for you. Elmeron is known for causing something called pigmentary maculopathy. We learned this about 6 years ago. The company has now paid $43 million to patients and their attorneys for patients who have gone blind. And the smallest settlement of the patients that I've worked with is $250,000. The largest settlement of the patients that I've worked with have been $1 million. This medication, back before it was approved in 1996, was found to cause eye issues back then. And yet somehow all the issues with eyes never made it into the patient education materials. And it wasn't until researchers at the Emory Eye Institute published a paper of 6 patients who all had this rare and unusual retinal disease that they now have correlated with using Elmeron. And now there are thousands of patients who have been affected. There are many, many research studies. We are working on a patient registry. I've got 2,500 patients in my IC network, Elmeron study. 57% report retinal disease in our study. There is also a big black box warning on it now that we're trying to get expanded to also include the bowel symptoms, because now it's also been connected, thanks to, again, the researchers at Emory University in Atlanta, with inflammatory bowel disease and something called polyposis, which is the uncontrolled growth of polyps in the bowel, so severe that patients have had to have colectomies and have their bowels removed. So the challenge that we have is that there are some doctors who are still trying to prescribe it, and they're minimizing the risk, saying, well, I've never seen any patient with retinal disease, so I think it's safe. And patients, they prescribe it and patients think it's safe. It's not. There's a black box warning on it. Millions of dollars have been paid out by the company. And interestingly, I got an email from one of our a retired doctor who's only seeing patients 1 day a week, and I had sent him an email giving an update on the Elmeron lawsuits and the polyposis, and he emailed me back and he said, ironically, Jill, I just had my first patient who had to have her bowel removed because of polyposis. Okay, so you got to learn a lot more about that Elmeron, and anytime it's showing any visual issues, giant flashing red sign. If you have any questions about that, feel free to call me. Jamie said, so what is the solution? Doctor switched me to estrogen cream instead of tablets. How do I restore my bladder health? Doctor won't give me estrogen because of my age. Well, it's not oral estrogen, it's topical estrogen. So they've given you cream, so that's important. When you give this skin, this atrophied, estrogen atrophied skin, estrogen, it immediately starts to plump up and make mucus. So you're doing the most important thing you can do to get that skin healthy. For some patients, that's enough. That's all they have to do. But for others, it's just not quite enough. And they have to do other therapies that will kind of protect their bladder. And that's usually going to be a chondroitin-based supplement like Bladder Builder or Bladder Rest or Cystoprotect. That's what most patients use who are in the estrogen atrophy group or who are coming off of Elmeron. Chondroitin coats the bladder wall. So chondroitin is an actual molecule found in the bladder wall that's essential to the superficial integrity of the bladder wall. Chondroitin is a treatment for IC throughout the rest of the world, not in the United States. So they put liquid chondroitin in the bladder as a bladder coating. The closest thing we have here in the United States is a chondroitin-based supplement. And what's really cool about that is something called bioavailability. And the bioavailability of chondroitin is really good at 25%. That means a lot of that chondroitin makes it through your gut intact to be able to do the job it needs to do. So Bladder Builder, Bladder Rest, Cystoprotect are going to, and Cystomen, those are the 4 chondroitin-based supplements. Peggy, what's the worst info you read online that you had to ban them for? I had a patient. So back in the day, we also had a live chat room that we opened every night that was moderated by support group leaders. And so, and it was really fun. I mean, we had a group of like 40 or 50 people that would come in every night and we would just talk about all sorts of things. I mean, we would take IC questions, but people got to hang out and it was absolutely wonderful. I had a patient come in to that group and tell everybody she told somebody to abort her baby and told everybody they should never have children, that this is a curse that's passed down. Okay, she got banned immediately. I had another lady who is on Facebook now. She got in a fight with, it happened in the middle of the night. Somebody called me and woke me up. He says, you got to get online right now, which I did. They got into this vicious fight about horses, of all things, horses. And one patient was cruel. I mean, the height of cruelty. Like I just, you come into a support forum for help. You don't come in to attack. And she was about as vicious as I've ever seen. So she was an older lady. And then there was this younger lady who was like in her early 20s who loved horses and was trying to ride again. I mean, just the little innocuous things that you can talk about. And over a period of a half an hour, 45 minutes, it descended into this, to this day, the single worst attack I've ever witnessed online. And so I split them up. I could see who the problem was. I cut her off right away. And then I took the girl who was hurt, and I immediately brought her into the chat room and made sure that she was okay, because she was treated as about as bad as anybody could have ever been treated online, and she was okay. She was very, very hurt. And I did everything I could to take that away, and I believe that I did a very, very good job. Unfortunately, 2 days later, she was killed in a car accident. She was literally killed in a car accident in Florida, the victim. And I was despondent that the last IC interaction that she had was with a patient who was vicious and cruel to her. And I think it wasn't that I failed as a group leader. I didn't. I got in there as quickly as I could. Somebody called me right away. Whenever anybody was suicidal, whenever anybody was in crisis, everybody knew to call me and wake me up. And I got up and I dealt with it. And I did that many, many times over the years. And I did that with her, and I got her safe, and I got her protected. But okay, so I had to deal with the older lady who was completely out of control. And she was furious with me for cutting her off. And I said, listen, you hurt her. You said terrible things, which I read. She's like, yeah, but she deserved it. And I just said, do you realize that she is now dead? That she died yesterday? And you know what she said to me? She went, good. I'm glad she's dead. You better believe I banned her ass like that. And then she came on Facebook and she started a group on Facebook. That was the caliber of some of our group leaders back then. I don't know. I haven't seen her in probably a decade, but that was the single worst thing that ever happened in my group. And there are just people, as many experts have explained to me, there are people. IC affects everybody, rich, poor, every religion, every age. And it also affects people who have the potential of being mentally ill. This person was severely mentally ill. It was very, very apparent. And as one doctor said to me, the problem is when you give somebody who's already schizophrenic or whatever pain, it's only going to amplify it. And that's exactly what happened. So now I'll tell you the other horrific thing I saw online. Well, a couple of things that I were here on Facebook. There was a gentleman who I had talked with regularly, who in fact called me like the day before he was in a car accident, and he wanted to know about clinical trials. Man, he was motivated. He understood it. He was like, there was no sign at all of any concern for his health. He was in great, great shape. And he was driving like through the Rocky Mountains, and they think that he swerved to avoid hitting a deer, and he hit a tree, and he passed away. And I didn't know it. I actually didn't know that it had happened until his family called me. And the reason why his family called me is because people on Facebook came online and decided that he had taken his life. And they even made videos about him committing suicide. And the family called me and said, "Can you please help us stop this?" And I said, "Well, what's going on?" They explained what was going on. It's like he didn't take his life. It was very clear there were skid marks. It was a deer, whatever. Please stop them from doing this, because they are just making it harder for us as a family to cope with the loss of our son and our brother. And so I'm like, okay, let me see what I can figure out here. So I get online and I quickly find what they're talking about. And I reach out to the people posting that. And I said, "Listen, the family called me and they've asked me to ask you to stop posting this because this is not true." And the people on Facebook said, "How do you know it's not true? We think it's true. We think he did it." And I'm like, "Well, the family has evidence that that didn't happen. And they are very respectfully asking you to stop pushing this." And they refused. They refused. They said, "No, you can't tell us what we're going to talk about. We think he killed himself, so we're going to say he killed himself." And it's like, in a situation like that, listen, the family comes first. You shut your mouth. You listen to what the family is asking of you. I was able to get the person who made the video to take the video down. So, I mean, there are many, many more incidents. I mean, not in our forum. Listen, our forum was locked down tight as a drum with 24-hour. I literally had 24-hour eyes on our forum. If there were anything even remotely questionable, they knew to call me. I jumped in really, really quick, and we nipped that in the bud. That doesn't happen in the online groups. And at a minimum, I'm just going to say this to all of you. If you're in an online group and you see somebody saying they want to take their life, man, do you know what you're going to do? You know why we had to shut down our forum? I mean, our live support group chat? I'll tell you exactly why. This just happened on America Online, not in an IC group. This was in another health group that I was not involved with. Somebody was in another live IC group, or not IC, other health group on America Online. They went into the group. They wrote that they were going to kill themselves, and they did online. And the family came in, and they saw them at the computer, and they saw what people were writing them. That people in the chat room were encouraging it. They sued America Online, and they won big. And that is the moment every live IC chat room, every health chat room shut down, like within hours. And that's why we don't have a live chat. And that's why you hear me talking. So, social media is the wild, wild west. And it is not what it used to be. And it is not healthy right now for anyone to be on social media for any given period of time. I really appreciate that you're watching this. I do the best I can to give you the most factual information that I can. But man, when we're done, I want you to get off of social media. I want you to go outside. I want you to hang out with your friends. I want you to go take a walk. And protect your soul. Because right now, you got to remember, the way they make money on social media is by keeping you upset. That's why everybody now has PTSD. That's why everybody now is struggling with changing their attention. The social media, there are companies in Silicon Valley who specialize in creating addiction online. These are consulting companies who work with app companies to make you so addicted you cannot turn it off. And how do they do that? By keeping you upset. Don't give them your money and don't give them your time. Go to the lake, sit by the lake, watch the ducklings. Listen to some music. Hang out with a friend. Let's get back to life before social media. All right. I can rant. Sorry about that. Brandon said, what do you recommend for lack of sexual desire with IC, or how to deal with a painful orgasm? As a man, I just don't feel sexy anymore, and I don't feel like I could satisfy a partner because of my IC. Okay, so Brandon, I'm going to tell you the story of a guy who called me, he was a famous politician on a Caribbean island. And, very, very well known, like the mayor of a city or a governor, something like right up there. And he diagnosed with IC prostatitis, and he couldn't work for a while, and his wife left him. His wife was a spoiled bitch and said, you can't keep me in the manner for which I am accustomed. I am leaving you. When people think there's this perception that it's the husband who leaves the wife with IC. No, actually, it's often the wife who leaves the husband with prostatitis or IC. And she bailed. She walked out, and he was broken. It's like, who would want me with this? What do I do? And I shocked him, and I said, I'd date you in a heartbeat. He's like, what? I mean, are you kidding? You totally get it. You totally understand it. I would absolutely go out with you if you were near me. 100%. Because that makes you a partner. That makes you somebody who understands the challenges. We could work together, And he was like, oh God, I never thought of it that way. It's like, absolutely. Absolutely. And so, Brandon, kind of just number one, you got to understand that men and women often have medical conditions that interfere with sex, and that a relationship isn't always built on sex, especially as we get older. When you're young, it's a very quick slam, bam, thank you, ma'am. But man, once you hit your 40s and 50s, it changes. It becomes slower. It becomes more outer course and inner course. It becomes a lot more about time and cuddling rather than actual intercourse. And one of the things that, I often say to women is, would you expect a man to be able to have wild, passionate, athletic sex with you if they had a broken leg? And the answer is no. So why do you think they should be able to have wild, passionate, athletic sex with you when they've got a broken pelvis, or they've got, a problem with their muscles or whatever? So one of the joys of getting older is that we understand health, and we understand the challenges of health over time. We understand that many men, as they get older, are going to have issues, and women, as they get older, might have issues. And God forbid you be an athlete and get injured. You're going to have issues. And God forbid you're a bike rider or a motorcycle rider. You're in all likelihood going to have issues. And relationships, number one, are built on communication, and they're built on trust, and they're built on time. On concept number 2 here is making sure that we really understand what's driving your pain anyway. And again, when people are having issues with intimacy, especially men, we're going to look at pelvic floor injuries, and we're going to look at benign prostate hyperplasia primarily. We want to make sure that if those are present, those are treated. If we can get those muscles relaxed and released, it should be a lot easier now. And then the same thing too is we also want to understand that, and I've shared this story before, listen, We had a doctor from the University of California, San Francisco Medical School, who came and spoke to our group about sex, the challenges of sex with pelvic pain. We were really, really excited. You know, my co-leader, Evelyn, found him. We invited him. He said, yeah, I'd love to come up. So we get to the hospital early where we were meeting, and we're all there, and in walked Santa Claus. I kid you not. He was a spitting image of Santa Claus. He had white hair, he had a long beard, he had a big belly, and he laughed a lot, you know, bowl full of jelly kind of. And we were just kind of looking at each other going, this is our speaker on intimacy. He goes, and, you know, we're like, what have we gotten ourselves into? He was fantastic. Absolutely fantastic. And he shared the story of a couple that were his patients that he had been seeing for some time. And he said, I don't even know why they see me. I envy them. I have never seen a couple more connected than this couple. They are happy. They are satisfied. They have a great sex life. They don't need me anymore. And I'm confused as to why they still see me. And he goes, and so we're like, okay. He goes, well, but there's one thing that's important. And we're like, what's that? He goes, well, he was in the war. Like, okay. He goes, well, he was injured in the war. We're like, okay. He goes, yeah. A landmine took off his penis. And we're like, wow. And the question that he asked us is, how can a man without a penis have a sex life that every other man envies? And he's like, legit, I envy them. I've never seen a couple so happy and satisfied with each other because they had become experts at outer course. And outer course, also known as tantric sex, is very, very different because it's about bringing your partner to that point right before orgasm when everything feels so good, then trying to keep your partner there for an hour, touching, stroking, licking, whatever. And y'all know that when you're at that point right before orgasm, it's great, it feels good, and you're lucky if it lasts a minute before, you know, you have your orgasm. So the goal of tantric sex is to keep a partner there. And he said, listen, once you've been at that point for an hour, you're just as happy as can be. Doesn't matter if you have an orgasm or not, you're just happy. And so he gave my group a lot of tips, and everybody walked out. I had young people, old people, straight people, gay people. I mean, it was a big meeting. And they all walked out with their heads together, just all kind of embarrassed, you know, laughing, really, okay, you know, and it was a fantastic meeting, probably the best meeting we ever did. The next month was amazing because those people came back glowing. And the couple that glowed the most were the 80-year-olds or the late 70s. You know, and it's like, you know, we asked, well, what'd you guys think? And they were like, it was great. And then this older couple said, oh my God, if somebody had just taught us this when we were in our 20s, our sex life would have been completely different and much, much better. You know, so sex isn't always about intercourse. Sometimes sex can be about outer course. And that is an absolute true story. And, you know, and then you say you don't feel sexy anymore. I mean, I don't feel sexy anymore either because I have no boobs because I had a double mastectomy. And that's in my head. And that's something that I just have to work on. that my lack of breath doesn't say anything about my ability to have sex. And I think that if you just, I mean, we all have to take responsibility for our appearance. We all have to try to, make sure that we look as good as we can look, regardless. But there are all sorts of people who like all sorts of different things. So don't give up. Just be open and honest. It's okay. There are many lessons learned as we get older. One of the things you gain is context and understanding. It's like, okay, why didn't that relationship work out? Okay, well, I get it now. We really weren't meant to be together. Why didn't that relationship work out? He was ready. I wasn't ready. I wasn't ready to have a relationship. Why did this relationship work out? And so I think it's important to be open to meeting other people with the goal of creating friendships first. I in all utter honesty, am not interested in sex right now because I have a lot of pain in my incisions. And if somebody came to me and said, let's have sex, I would probably want to slug them. I am not ready for that. I am genuinely traumatized from my surgery. But that doesn't mean that I don't want to have a good friend. That doesn't mean that I don't want to play games. It doesn't mean that I wouldn't love to go to the gym with somebody or go take a walk with somebody. And when the time is right, the time is right. And when the time is wrong, sometimes we just have to kind of go with the flow. Hello, Gay. It's so nice to see you. Jamie said, awesome. Sister Protec was on my list to look into. Yeah, Sister Protec is an older formula. I think that the top supplement right now, according to reviews, is Bladder Builder by far. And the reason why is because it contains another ingredient called PEA, which actually reduces pain. And there's a lot of research showing that it reduces pain by calming nerves down. So Bladder Builder is chondroitin with PEA to calm the nerves down, along with some quercetin and stuff like that. So usually I suggest that patients try Bladder Builder first. I just genuinely believe it's the best supplement out there. Allison said, you've had the eye test twice at opticians in the United Kingdom and it's okay so far, but this is scary and I've been proactive about this. How do I get your number? Can I get chondroitin in the United Kingdom? Could you repeat the names of those supplements, please? Allison, we can do a Zoom. Here's my email, icnetwork@mac.com. I work with a lot of patients in the United Kingdom. Just email me and we can set up a time to talk on Zoom, okay? I have a little United Kingdom Amazon shop with some products that might work. We can't send products to you because of Brexit, but I have several suggestions that might be helpful, okay? Noreen said, is taking marshmallow root and quercetin good for the bladder? Marshmallow root has a soothing quality to it. Unfortunately, it also flares some people. I think it's kind of a 50-50 split. Half the people who try marshmallow root do well on it, and half the people who try it report that it flares. So it's not at the top of my list. And again, with phenotyping, the only role for marshmallow root is and aloe is going to be short-term use for a bladder wall flare, in my opinion. Quercetin, as long as it's the right quercetin, which is usually from the Sephora plant, rather than citrus bioflavonoids, quercetin has an anti-histaminic effect to the bladder. You're going to find quercetin in all of the good chondroitin-based supplements already, like Bladder Builder, Bladder Rest, Cystoprotect, and Cystomend. Peggy said, thank you for all that you do. It's so crazy to hear that people can be so cruel to each other. Well, this is social media. I mean, y'all understand that if we were all meeting in a room together, nobody would ever say what they would say to each other. Social media gives them an anonymity, allows them to say things they would never say in person. And that's the fundamental reason why social media is a horrible environment for an open support group. And Facebook in particular is notorious. I mean, there was one group on Facebook that's still active now that kicks out all men because they don't believe men can get IC and pelvic pain. What can you say? Allison, I hope you're well. Can any of these cause a flare? Zepbound Cymbalta has triggered adrenergic POTS, progesterone, and estradiol patch. Yeah. Any of those have the potential of triggering a flare if you're sensitive to any of the ingredients. Estrogen is somewhat notorious for causing unexpected flares in some patients. Sometimes it's just the fillers that are in the estrogen. So, yeah, I think it's possible. She says, I'm in a flare and I think it's one of these things, but can't pinpoint the trigger. Okay, so Allison, we would use the 10 questions that I started these meetings to try to figure out where that pain's coming from. Question number 1 is, when is your pain the worst? Before you pee or after you're done peeing? Jamie says she's taking PEA. Great, I am too. Brandon says, Jill, I think you're a very sexy lady, mastectomy or not. You look great to me, and I think you would be the coolest friend to have. Thank you, Brandon. And I would totally love to be your friend too. And David too. The challenge, and I was thinking about this yesterday as I was driving around. When you have something that drives you to a restroom, it's a life that other people don't understand. That going to a concert, like I was invited to go to a concert with a friend, and I just said, aisle seat. I don't want to be in the center of a row. Give me an aisle seat where I can get up and run to the bathroom. And she's like, yes, of course. It's hard though, because we tend to lose the friends that we had before this, because now we can't do what we used to do with them. Most of my friends were tennis players, and I have no contact with any of them now. Any of them. And that it gets lonely. And I will confess that I have suffered from loneliness for years off and on. And I've gotten very good at, I can live by myself. It's fine. I can take care of myself. It's fine. But I love it when people drop by suddenly, I want my home to be a place where anybody is welcome. I wanted to be that mom where all the kids wanted to come hang out, but unfortunately I couldn't have children. So I think that I'm going to restart an in-person support group here in Northern California again. Because I just think we need to be friends. We all need more friends. I know I need friends. Allison said, so essentially, I don't think it's just a pelvic floor issue because I have bladder and some flank pain around the kidney. Oh, wait. Here, hold on a sec. Wait. Pain is before mostly, but after peeing, see. But I think pelvic floor is irritated as a result of something hitting the bladder. I used an estradiol patch. So essentially, I don't think it's just a pelvic floor issue because I have bladder and flank pain around the kidneys. Yeah, but honey, your psoas muscles, which go, the big giant rope muscles that go up your spine, go straight down into the pelvic floor and connect into the pelvic cavity and connect to the pelvic floor. So it actually could easily be a pelvic floor issue. But another thing that we want to look at is it fundamentally a joint issue? My pelvic floor is always tight on my left side, and that's because my SI joint is unstable. And until I get the joint fixed, my muscles are always going to be tight on that side to compensate for that. So, and then also too, the bringing up the kidneys opens up a whole nother can of worms there. Are we dealing with a kidney stone? Are we dealing with anything funky going on with your kidneys? I mean, if you're having low back pain associated with kidneys, your doctor needs to do a proper workup to make sure everything's okay with your kidneys. Jennifer on YouTube says, thanks for everything you do. It took my doctors 4 months and my diagnosis is pelvic floor. Yay! Now we know what your diagnosis is. This is good. Excellent. At 57, I've had both cataracts fixed. It could have been from hyperbaric oxygen therapy because I only had 3 months of Elmeron. Elmeron's not associated with cataracts. Elmeron is associated with retinal damage. So cataracts are on the cornea in the front rather than the back of the eye on the retina. So I'm not aware of any Pentosan issue with cataracts, but you know what, just out of curiosity, let me look at it. Hold on. I'm just going to go to the National Library of Medicine real quick, and let's just see if there are any reports of Pentosan and cataracts. Oh, one article came up. Hold on a second. Wait a minute. Update on retinal drug safety. Hold on a second. Oh, no. That's interesting. So there is a Research and Safety and Therapeutics Committee and webinar that was held in 2024, comprised of members of the American Society of Retinal Surgeons. A regular internal meeting, safety issue reports from the website are reviewed. A webinar was started in 2021. Topics reviewed included the first topic, pentosan polysulfate maculopathy. But there a lot of other things too. But anyway, no, I'm not seeing any discussion of anything with pentosan linked to cataracts, my friend. Jennifer said, what is my opinion on stem cell therapy of IC Hunners with IBS and tight pelvic floor issues? So Dr. Elliot Lander, who is at the California Stem Cell Center, was the first American doctor to really dive into the role of stem cells for IC. And he did a patient-funded research study where what they did is they harvested a patient's own stem cells by doing liposuction. So they would take the stem cells from fat tissue. So they do liposuction, grab a patient's fat, and then blend it up and break it up into what they called stromal vascular faction, SVF. Yeah, stromal vascular faction. So imagine, so what they did is they took out all the stem cells and all the growth factors out of the fat, and then they re-injected that into patients. So they gave the patients their own stem cells back, which then minimized rejection, all that sort of stuff. I mean, it's basically your own tissue being given back to you. His results were initially exciting, that patients seemed to be doing better with stem cell therapy, but it was short term, that it wore off after about 6 months, and then the patients had to come back and have it done again. And unfortunately, the problem with stem cells and that method of stem cells is that there's no pharmaceutical company that's funding it, because it is impossible to get a patent on it, because every treatment is different. And so there's no financial incentive for anybody to put $1 million into it to study the real effectiveness of it, or $5 or $10 million for research. And back then, patients had to pay $6,000 a pop, $6,000 a pop to have this done. So it was not cheap. So they stopped doing it. Now, since then, China has done a lot more stem cell research, and they've taken stem cells from placentas, human placentas, as well as stem cells from a patient's own fat. We just had another study that came out like in the last month to 6 weeks. I am not seeing any long-term effectiveness with that, but I will admit that I haven't looked at the more recent research closely in the last couple of years. What's far more important here about your case is that you have Hunner's lesions. I want to know what's driving those lesions, because a stem cell therapy is a shot in the dark. It's a guess. And you deserve more than a guess. We need facts. We need to try to understand what's driving that lesion formation. So number one, is it a virus? Number two, is it neuroinflammation? Or number three, is it a broken ligament that's causing posterior fornix syndrome? That's where I would spend my money, is making sure, number one, that you don't have a viral infection. Number two, that going to a gynecologist and getting your uterosacral ligament checked to make sure you don't have a damaged ligament that's damaging the nerves in your bladder, causing the lesion to develop. And then I would also be looking at lactoferrin, because we've got a solid research study showing lactoferrin helped Hunner's lesions heal. Stem cell, I mean, let me look at it though. Here, hold on a second. Let me go to I'm back at the National Library of Medicine, and stem cell Hunner's lesions. Let's just see if there's anything. 8 studies. Okay, so hold on a sec. So let's look at this real quick. Okay, May 2025, a single center phase 2A trial of HESC-derived mesenchymal stem cells for the safety and efficacy of IC patients. We have a full article on that. So here, let's just look at that real quick. So this study was done in Korea, South Korea. Okay. A lot of respect for Korea. Okay, so these came from human embryonic stem cells. So this study investigated the safety and efficacy of mesenchymal stem cell therapy derived from human embryonic stem cells in patients with IC, particularly those with Hunner's lesions, conducted as a prospective randomized double-blind placebo-controlled phase 1/2A study. It enrolled 22 patients. Half were dosages. So let's just get to the results here. There were no dose-limiting toxicities, only mild adverse events, such as transient hemorrhage and bladder pain. So 12 patients received stem cell therapy, 4 received placebo. Significant reductions in IC symptoms were observed in the treatment group, especially with nocturnal voiding frequency and Hunner's lesion size, with 8 patients showing a reduction or complete resolution of the lesions after 6 months. A global response showed moderate to marked improvement in 42% of patients versus 25%. But what they don't say is how long the effects last. And that's what Dr. Lander, that was his issue, was, yeah, they help, but only for 6 months. So that's encouraging, though. Okay, here's a study from July of 24. Where's this from? Also Korea, Seoul, Korea. Only one clinical trial has investigated the state. Okay, so this is just an early study of that same one. Let's see if there's anything. I don't know. I think it just depends upon how expensive it is. I mean, I consider it kind of a shot in the dark. I would, yeah, definitely kind of a shot in the dark. Jennifer says, I think it's hyperbaric oxygen therapy and the cataracts that are related. All right. Let's see. All right, let's look at that. Hyperbaric oxygen therapy is a rare but documented catalyst for cataract formation and progression. While a standard short course of 20 to 40 sessions is highly safe, prolonged or repeated hyperbaric oxygen exposes the eyes to oxidative stress, which can cause cataracts and temporary vision changes. Okay. Okay, and then Jennifer says she did the lactoferrin and it was amazing. Hey, there you go. You did the lactoferrin. It was really helpful. Great. Excellent. That's what I like to hear. That's what I like to hear. Hello, Inga. Inga says, I'm in the United Kingdom in a horrendous flare at the moment. Can it show blood when it's just painful? My GP hasn't given me anything. The answer is no. IC does not normally show visible blood unless it's a Hunner's lesion. If you've got blood in your urine that you can see, if your urine is pink or red or you're passing blood clots, very first thing we're going to look for is infection. That is a trip to urgent care. If you have urgent care in the United Kingdom, I would get there quickly if you've got visible blood in your urine. I'm sorry you're going through that, honey. Brandon said, would you think I'm crazy if I told you DMSO helped with urethral pain? They only gave it to me for 15 minutes before they drain it. And it gave me an anesthetic cocktail. I'm having good results with that because I discovered I have the bladder wall phenotype 2. Well, I mean, if they gave you an anesthetic cocktail, it's probably the anesthetic cocktail that's helping more than the DMSO. Allison says, do you think that sublingual B12 vitamin that I let sit under my tongue and then spit out could impact the bladder? No. Unless there's a filler in it. B12 has always been bladder friendly for the vast majority of patients out there. Aaron says, my urologist told me that my amitriptyline is not causing my heart issues. I'm on 25 milligrams. I was so confused because it's all over WebMD. I don't understand why they are ignoring this. Question, can I take the PEA supplement while weaning off the amitriptyline? There's no known drug interactions with PEA. I don't see why you wouldn't be able to. But, speaking as somebody who had serious heart complications from amitriptyline, that offends me. Like, you have a doctor who's just like not even willing to consider that amitriptyline can cause heart arrhythmias? My God. I mean, I took amitriptyline for 3 months and it turned on a third node in my heart. There are two functional nodes in your heart, your AV node and your SA node, and they control your heartbeat. So your heartbeat's normally beep, 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 beep as these nodes fire. My heart rate at 3 months went beep, 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 beep. And sometimes two would beat at the same time. So it'd be a beep, 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 and my whole chest would vibrate. Scared the living daylights out of me. And I ended up wearing a heart monitor for a month as they were documenting all of this, watching what my heart was doing. And the hardest thing about moments like that is it's like a cancer diagnosis. You're scared to death when they tell you you've got a heart problem and then they send you home. It's like, wait a second, am I going to live? And it's just, I was shocked that nobody held my hand and said, you're going to be okay. And it was in this very room where I am now. This was not an office. This was a bedroom that where I did my treatments back then. And I was so scared of what my heart was doing that I just said to myself, you've got to divert your attention. And so I started making dolls. I made stuffed rabbits. In fact, I just found the pattern that I used. And really intricate things with cute little clothes. And I entered in the fair and I won first place in the fair. I just wanted to be able to look back at the scariest period of my life and go, look at what you did. Look at what you made. And I still do that now. I only have paint now. Or I quilt, whatever. I mean, a happy place for me is a craft camp. I don't need to go to a fancy restaurant or travel to Europe. If you want to make Jill Osborne happy, let's go to a craft camp together and make stained glass. That would make me very happy. Aaron said that they stopped because of my video and my side effects. Shelley said, I also tried amitriptyline for 2 months, caused you terrible arrhythmias. Yeah. Aaron said, I've been on it off and on this drug for 3 years. Yes, I was having scary heart episodes at night. Yeah, and why does it happen at night? For God's sakes. It'd be nice if it happened at 10 o'clock and you could just freaking drive yourself to the ER. When it happens at 2 in the morning, it's just scarier. And honestly, I think I've been to the ER. I was at the ER, I don't know, 10 times in the last 2 years, most with heart arrhythmias. Well, and, gallbladder stuff too, and breast cancer stuff too. I just drive myself now. My heart goes bonkers. I'm on medicine now. I'm on low pressure, and I'm on a heart stable. I know. I feel much better being on it than not being on it. I just don't like the feeling of things happening here. I don't like the feeling of that heart racing. Yikes. It's not fun at all. And there was another IC med. God, what was that? Somebody just like 2 or 3 days ago. And I think it was amitriptyline. And they had a really rare side effect, like a really unusual side effect from it. I don't remember what it was. Aaron Alicia says, "Will PEA shut off fight or flight?" Well, it will calm the nerves down, but it's not gonna shut off fight or flight. You got to shut off fight. Thank you, Katie. Yes, metoprolol. I do 25 milligrams of time-release metoprolol every morning, and I have extra 25 that I'll take if my heart gets funky. And sometimes that's not enough. And if I go into AFib, they've just got to give me more. This whole AFib thing, like, holy hell. That's only been the last 18 months from the COVID vaccine. And I'm not an anti-vaxxer. It's a well-known complication of the COVID vaccine. So getting back to Aaron, will the PEA shut off fight or flight? No, you have to do that. Let's talk about that. Let's talk about that for a moment. So when we think of our phenotypes, so we've got, Chris Payne's 5 phenotypes. Other systems combine some of Chris's. Chris breaks his out. He's a friend of mine. He breaks his out. Everybody, yes, Katie, yes, I'm on a blood thinner too. I'm on Eliquis too. I'm glad I have health insurance. Okay. Anyway, the widespread pain phenotype are the patients with the IC and or IBS and or vulvodynia and or TMJ and or fibroid and or migraines, characterized by very sensitive skin, wicked sense of smell. Sometimes we're very light sensitive, or sometimes we're very sound sensitive. I once heard my cat, I was sitting at the kitchen table at dinner. I heard my cat meowing in my neighbor's locked garage. Okay, the extreme sensory sensitivity is common in patients with widespread pain. So the question then is, why does that happen? And the Chronic Pain Research Alliance found out why that happens, that we have the equivalent of an injury to the central nervous system. We call this a central nervous system maladaptation, injury, trauma. What the research shows is that for 80% of the kids who grow on to develop the super sensitive nervous system and these other conditions, there is a major physical injury. It takes 14 days of pain to put the central nervous system into a constant state of fight or flight. For the other 20%, it's a history of abuse or bullying. And in my office, I'm just going to say the most common theme in my office, virtually every single day working with patients, is somebody who grew up in the home of an alcoholic. and or a violent alcoholic. Almost every, I mean, now that we're phenotyping, when we find these patients and we explain context and history, it's all about, you know, what was the trauma? And most importantly, taking all the shame away and all the blame away entirely. I have worked with many, many patients who have had horrific abuse performed on them. I won't even begin to describe some of the stories that I have been told. And what a great tragedy it is that innocent children are hurt, often every day, often their entire childhood, by a mentally ill or an abusive or alcoholic parent, violent alcoholic parent. So this then helps us put fight or flight into context, because in the end, it's about how does a child's brain try to protect them from trauma? The brain stem is the most primitive part of our brain. It has one job: to save our life. The brain stem monitors sensory input. What do you see? What do you hear? What do you smell? What are you tasting? What are you touching? And if the brain stem senses a threat, the sound of the car with dad or mom in it pulling into the garage, the sound of the back door opening, the sound of the beer, the sound of raised voices, the sound of anger, that child's brainstem is activated. It knows a threat has happened in the past. It is actively trying to prevent this child from being injured. And the way that it does that is by putting that child into immediate fight or flight as soon as the threat is detected. Now, normally, fight or flight is short term. If you open up your front door and you see a saber-tooth tiger, oh, hell yeah, you're going to go into fight or flight. You're going to slam the door. You're going to call the authorities. They're going to come out, and an hour later, the tiger has been tranked. It's gone. The threat is gone. Fight or flight is supposed to turn off. But it doesn't turn off for us. For some of us, myself included, it stays in the stuck on position. Why? Because of trauma. It is our brain saying, we got hurt in the past. We don't want to get hurt again. We are hypervigilant. It is hypervigilant looking for threats. And the challenge here is that when you're in a constant state of fight or flight, your nervous system just gets more sensitive and more sensitive and more sensitive. And then what does it do? It amplifies pain, and the pain gets out of control. So I have shared that when I was young, I was attacked by a rapist murderer. And the year I went away to college, he raped and murdered my neighbor. I looked over my shoulder for a decade. I did not leave my home without fear for a decade. God's honest truth. And when they called me at college to say he had raped and murdered my neighbor, I started screaming, because I knew that would have been me if I'd been home. 100%. He hurt a lot of people. A lot of people. And we have our victim reunions. You know, when we do our high school reunions, we have our victim reunions. And lives were indelibly changed by the trauma that we lived through when we were kids. And so the secret now is understanding that, number one, we are safe. What happened to us as kids that was decades ago. And one of the blessings of being older is we know how to protect ourselves, and we know that we can call for help. And we know we can walk away, and we know that we can get in the car and drive away. We are safe. We do not live under, and the alcoholic is in all likelihood probably dead. The threat is over. But we have to remind our brain that we're safe. And that gets really hard, because one of the things that our brainstem does, because again, it has one job: to save our lives. How does it do that? It changes our behavior. So I never understood why my entire life, from that moment when I was attacked, every invitation I received, before they could even finish it, I said no. Now, I legit wanted to do everything I was invited to, but before I could even think that, out of my mouth popped, no. No, I'm sorry, I can't do that. Or what happens is your brain starts to catastrophize. It's like, okay, you're on it now. It's like, okay, wait a second. That's just a thought. It's not powerful. It's just my brain trying to protect me. I mean, so like, why did my brain say no? Because being home is safe. My brain perceives going out the front door as dangerous. So my brain says, stay home where it's safe. That's called guarding. It's called, and I was at this fantastic anxiety management class. That was one of the very first points the instructor said is, how many of you say no to every invitation? And we all raised our hand. We all looked at each other and went, oh my God, you too? He goes, you know what that is, don't you? Or like, no, that's just your brain guarding you, because you've been through stuff. Your brain is saying, don't go do that. You might get hurt. Stay home where it's safe. But then you get on it. Now you're recognizing that's the way your brain behaves. So you start ignoring it. And then what happens is your brain gets really, really creative, and you start to catastrophize. So you just don't think, no, I can't do that. You're going to go, oh no, if I get in that car, I'm going to get in a really bad car accident. I'm going to be hurt. Or if I get in that car, there's going to be a horrible traffic jam. I'm going to be stuck in the car for 3 hours and I won't be able to pee. Or no. If I go to that restaurant, I'm going to have a really bad flare. Or, oh no. If I go to that movie with my friends, I'll have a terrible flare and I'll have to leave early and I'll ruin it for them. That was a big, big thought for me whenever I was invited to the movie. And that's just fight or flight on steroids. That's fight or flight working really hard to keep you home. So what this class taught me is, number one, I wasn't alone at all. Number two, so, the first thing he said is, how many of you say no? And we're like, we all do. Oh my God, you too? That's crazy. And it's like, how many of you are sensitive to medications? We all raised our hands. Yeah. And how many of you are really sensitive to smells? Like, we all raised our hand. And how many of you are super sensitive to chemicals? And we all raise our hands. He's like, you know what that is, don't you? We're like, no, that's just your nervous system has become very, very sensitive. And not only are you sensitive to chemicals on the outside, you're also more sensitive to chemicals on the inside. And he said, right now, every single one of you in this class is overdosing on adrenaline. You have so much adrenaline shooting through your body. Adrenaline is the primary neurotransmitter for anxiety and fight or flight. He said, you have so much adrenaline shooting through your body right now. That's what's driving the tears. That's what's driving the rapid heart rate. That's what's driving the nausea. That's what's driving the panic and anxiety. It's just, you have a massive amount of adrenaline circulating through there. And he said the secret to controlling anxiety is we got to get rid of the adrenaline. because the adrenaline, the adrenaline is kind of like caffeine on steroids. The more adrenaline you have, the more fight or flight you're going to be in. So we're like, how do you do that? And he goes, it's actually really easy to turn off adrenaline. Oxygen turns off adrenaline. Like, okay. So he said, I'm going to teach you a tip that's going to bring your adrenaline levels down to almost normal. We're like, okay. He said, the challenge is you're having so many scary thoughts. Every time you have a scary thought, you have a jolt of adrenaline. And the thing is you don't just have one negative thought a day, you got hundreds a day, which means you got hundreds of shots of adrenaline circulating through your body at any given time. So that's what we're going to work on. And then he explained, what I explained earlier, that the catastrophic thinking is just the brainstem just kind of overreacting, worried that you're under threat, even when you're not under threat. Okay, so he taught us a 3-step technique that I use to this day. I have not had a panic attack since I took the class when I was 35. That is 30 years. I've only come close once because I learned how to stop the adrenaline. And so he said, every single time you have a negative thought, the very first thing you do is close your eyes and just visualize a stop sign. And you're just telling your brain, stop it. I don't want to hear this anymore. Stop. So you have a negative thought. I don't want to go to a movie because I might have to go to the bathroom. Just like, stop. Take a single deep breath in for 3, out for 5. Or you can do 4, 6, whatever. That deep breath has now rendered the adrenaline from that negative thought chemically neutral. It is done. It is over. It will never build up in your bloodstream. So scary thought, it turns on the adrenaline. The oxygen turns the adrenaline off. So stop sign, deep breath. And then the third step is you have to remind yourself it's just a thought. It has absolutely no power at all. That's just your brain trying to keep you home or trying to do whatever it's trying to do, depending on where your threat was. So you got to remind yourself that. So what I say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all you know, this trip is going to be the best trip of your life. It's just your brain. It's just trying to guard you. You're safe. It's okay. You can do it. Stop sign, deep breath, minimize the thought. Okay. And they said, okay, for this next week, before our next meeting, all I want to do is bring down your adrenaline levels. And I promise you, if you do this, it will work or it will help. And of course, I'm like, hey, man, I got nothing to lose. I am sick of living with anxiety. I am sick of panicking because I was panicking before getting on a plane and I was panicking before going to the doctor or going to the dentist. And I had a master's degree in psychology and I couldn't turn off the panic. That's why I took the class. I finally dawned on me, clearly you're missing something. You better go learn some new skills. And that's why I signed up this class. Okay, so anyway, stop sign, deep breath, minimize that. He said, okay, for the next week, I want you to listen to what you say and I want you to do it. Every single time you do if a remotely scary thought, just do it. We're just trying to bring the adrenaline level down. And I'm like, okay, I get it. I like the chemistry. I can do that. And of course, I had my first negative thought walking out of the room. It's like, oh my God, this is so stupid. It'll never work. But I did it. Stop sign, deep breath, minimize that thought. And what amazed me is that I had gotten so used to all the negativity that I just kind of tuned it out. But when I actually stopped and listened to what my brain was saying, it's like, oh my God. I couldn't believe how many negative thoughts I was having. And more so, most of them were about me. Like, oh my God, Jill, you're such an embarrassment. What's wrong with you? My self-esteem was horrific. horrific. It was just horrific. I blame myself for all of this. And I got a really good lesson in self-esteem at that point in time. And that's why when you work with me, like the very first thing I say is, it's not your fault. It wasn't my fault either. I was a victim of trauma. So were you. Okay. So anyway, that first day, I did it at least 100 times. Second time, about 50 times. Third day, about 20 times. Fourth day, I don't know, 5 or 6 times. 5 days later, I only had to do it once. And it was a revelation how good I felt. And I realized that I had been in fight or flight my entire childhood, from the age of 4 when I was attacked all the way to the age of 35. I had been in fight or flight that entire time. And once I got it, once we brought the adrenaline level down, everything calmed down. The panic attacks went away. The tears went away. The nausea went away. The dizziness went away. It all went away when I got the adrenaline down. That class was called Phobies. It was taught by an orthopedic surgeon with anxiety disorder. And his son had anxiety disorder, and he created this class for his son. And I am so incredibly grateful. And so now, number one, I understand that when I have a negative, scary thought, I know where that's coming from. That my brain is remembering trauma, and for some reason, I don't necessarily feel safe. And so I will allow myself to have one negative thought. But if I have 2 in a row, stop sign, deep breath, minimize thought. It's very rare that I have 3 in a row now. And I will tell you, I went from having hundreds of negative thoughts a day to maybe having 1 or 2 a week. Now, as you can see, if you look at my backyard, I am very purposeful in how I live. My home is a happy place filled with things that make me smile. I got flowers everywhere. I got cats everywhere. I got inspirational quotes everywhere. The drapes are open. The sun is shining in. If you want to destroy the soul of Jill Osborne, you put me in a dark room underneath the freeway, and I don't think I'll last very long. I need to be out in the sunshine. And I was doing really, really well until COVID hit. And that was scary. And I started feeling more anxious. But you know what? I had a system. Stop sign, deep breath, minimize thought. And I never, ever let it get out of control. It's so easy to visualize a stop sign, take a deep breath, and just say, you know what? I'm safe right now. There's no reason for my brain to be doing what it's doing. The irony is that I have 1 negative thought a day right now. And it is always about an earthquake. Do not ask me why. I have no idea why my brain does that. It did it this morning. At least once a day, my brain goes, is this the day the big one's going to hit? It's probably PTSD. So taking a class is a great thing to do. Class is going to focus on new skill. There are a number of things that you can do to bring down and bring your brain out of fight or flight. And I wrote a big magazine on it. Oh God, do I have it up here? There are a number of techniques you can use. You can do tapping. That will reset your nervous system. With tapping, you tap different parts of your body And you're kind of just, again, it's just about triggering nerves to bring them down. So you can do tapping, you can do cognitive behavioral therapy, you can do deep breathing, 4 in, 7 out. I mean, the best technique of all is just deep breathing. Like breathe in for 4, breathe out for 7. I did that in the car while I was driving a couple of times yesterday. And I think having people to talk to. I did not talk about my trauma for many, many years. And I didn't start talking about it until the new research came out. I never even talked about it when I was getting my master's degree and when I was in therapy. I was too traumatized by it. I didn't want to relive it. Now I talk about it all the time, and it's okay. Because it helps me understand my life. And I think that now at the age of 65, I can absolutely see the toll that trauma took my entire life. That every single major life decision I made from a traumatized fight or flight brain. And I don't want to live that way anymore. And I'm working hard not to live that way anymore. I had a lot of opportunities to fly around the world, talk about what I see, and I said no to almost all of them. Anyway, so anybody else out there, if you're struggling with anxiety, give me a phone call. We can have a chat. Noreen said, is eating cookie or something sweet bad for us to enjoy? No, I think reward therapy is important. If you're working hard, you deserve a reward. The question is, does that mean you're going to eat a whole box of cookies, or you're just going to have one cookie? Stick with one cookie. It can be a big cookie. I got a big cardamom roll yesterday. It's like I just driven 50 miles. I came back. Man, I'm going to have a roll. I'm fine. It's okay to reward yourself. I just think that you also have to understand that sugar, you don't want to eat a lot of sugar. You just got to be normal. Sugar feeds cancer. When they give cancer cells sugar, they start to vibrate and grow. And the American diet is so horrific. We have way too much sugar in our diet. My God, they put it in everything. And so I would look for another, how about taking a warm bath and lighting a candle? That'd be a nice reward. How about making a smoothie with some fresh fruit? Trying to kind of step away from the baked goods into something, or even go into the, just look for other ways to reward yourself. But is it okay to have a cookie every now and then? Oh, yeah. I would stick with like a pumpkin cookie or a snickerdoodle. I would just stay away from like a chocolate chip cookie or a chocolate cookie. Jill said, hello, Jill. Nice to see you. It's always nice to see other Jills. I went into remission for my IC when I got on Cymbalta and an antihistamine at the same time. So who knows? But it could be a coincidence, but I sure as heck, I'm not stopping either one of them. I was in pain for 5 years. So concept number 1 here is you may be an allergenic cystitis patient. Your cystitis just may be driven entirely by allergies and sensitivities. And so the antihistamine may be nipping that sucker in the bud. Some doctors believe that allergenic cystitis is a unique phenotype, specifically Curtis Nickel up in Canada, and I agree with that. Cymbalta is trickier in the sense that I'm trying to remember, what is the mechanism of action of Cymbalta? Hold on, let me look it up. It's an SNRI used to treat depression, anxiety, fibro, chronic nerve, or joint pain. It works by increasing levels of serotonin and norepinephrine in the brain that help regulate your mood and pain. So if you're seeing me hesitate, because you're here, I am hesitating. The challenge with medications like Cymbalta is something called a discontinuation syndrome. So what that means is that getting off of it is very hard and tricky. You can't cold turkey getting off of Cymbalta, like just decide you're never going to take it again. You will probably hallucinate for months. I had one patient, she literally hallucinated for 6 to 9 months after trying to get off Cymbalta and cold turkeying it by not taking any more. That's called the discontinuation syndrome. So there are a number of meds who have this. Lyrica is another medication that does this. So if you ever do decide you're gonna try to get off of it, you just have to reduce the dose very gradually over time, okay? Very gradually over time. So it might take 6 months to get off. It might take 3 months, 6 months, 9 months to get off of it. So, hey, listen, the point is it's working for you. I mean, you were in terrible pain. Now you're not in pain, and that's good. You're functioning. You have a life again. So as long as you're not dealing with any other really severe side effects, perhaps from the Cymbalta or the other medication, I mean, it's clearly helping you. I just think that it's a perfect example of managing symptoms rather than fixing the underlying problem. I would like to know what the underlying problem is. I would like to know what could be driving those intense levels of pain, and can we treat that so that you don't have to use the Cymbalta? And so, you know, cause versus effect, or fixing the problem rather than chasing the symptoms. I would just want, if I were in your shoes, I would always be asking, why am I in this pain? Is there anything we can do to try to reduce that a bit more? You know what I mean? I hope that makes sense. Here, hold on a sec. I need to look something up real quick. Hold, give me one quick sec, real quick. I just heard my phone ring, and if it rings on Sundays, bad things can happen. And I've got a family member who is near death, so I wanted to make sure that something hadn't happened. Looks okay. A cousin of mine. All righty then. Okay. So we started this meeting talking about questions that will help you identify where the pain is coming from. And if you were on the phone with me, this would be, first thing I would ask you is, how old are you? Second thing I would ask you is, how old were you when your symptoms started? I want to know if it's short-term or long-term. And the third thing I'm going to ask is there any event that you associate with the onset of your symptoms? Listen, your intuition is very, very good. And I always want to listen to what the patient says. The patient's story is 90% of the time pretty spot on and correct. It's just getting the doctor to listen that's the hard part. Noreen wants to know our phone number. It's an 800 number. 800-928-7496. And again, it's a first come, first serve. If you call and you get a text back saying, I can't talk right now, or can I call you later? Don't take that personally. That just means I'm already working with somebody. I will call you back when I can. Okay. Okay. So let's just go through these 10 questions real quick one more time. So these are the questions that will help us figure out where your pain could be coming from, because it feels like your bladder. You're sure it's your bladder, but guess what? In many cases, it's actually not your bladder. So the first question that I'm going to ask you after we go through age is, do you have any external pain? Do you have any pain on your skin down there? Vulva, vagina, etc. Tip of the penis for men. If you have external pain, that's not your bladder. That's something else. For women, it's often just estrogen atrophy. My next question is, if you have internal pain, where is that pain? I want to know specifically where it is. It doesn't work for you to say down there. It's like, no, you got to give me more information than that. Is it in your bladder? You have pain as your bladder fills with urine that is relieved by urination. Is it in your urethra? Do you have sharp pain in your urethra? That's usually how it presents, a sharp, quick pain. Do you have any pain in your rectal area? Do you have any pain in your vagina? Do you have low back pain, tailbone pain? If you have any of the others, then that's probably not your bladder. That's probably something else going on. Jill says here, bingo, you nailed it. I have pain in both places, but mainly in the area you're talking about that's not the bladder. Exactly. Exactly. So the question is where, Jill? You have pain in your vagina? You have pain around your rectum? Tailbone? Okay, the next question I'm going to ask is the location of the pain in a different way. Is your pain centered, or is it to the left of center or right of center, or is your pain just on one side? I had a gentleman say, I mean, he's like, I've been diagnosed with IC, my bladder pain's terrible. And I went, like, where's the pain? He goes, there. And I went, where? Put your hand where your pain is. He said, okay. I said, where's your hand? He goes, by my left hip bone. And I'm like, well, that's not your bladder, honey. He goes, really? And I'm like, no, your bladder's by your pubic bone. If you have pain by your left hip bone, that's your hip. Okay, hold on a sec. Jill said, urethra, I feel it in the urethra, main pain, but it's awful, and it's been happening except every once in a while now, and it gets better after baking soda. So Jill, urethral pain is often estrogen atrophy. Darla says, how do I get estrogen treatment? My gyno says all my levels are fine. It's not about blood testing. It's about them looking at your skin, because atrophied skin presents in a very specific way. And a lot of people get their levels tested and it appears fine. But when you look at their skin, you see atrophy happening. So I would have them look at your vulva. Let's see how healthy your vulva is. Now, if they say, I mean, Darla, how old are you, hun? Okay, Jill says, I can't have estrogen treatment because I'm a blood clot survivor in my leg, and that I hit and injured. You got a blood clot and they took all my estrogen away. I hate them for that. Okay, you're not alone. That actually happens too. So then what you're going to do is, where is it? Here it is. So, you know, from a supplement standpoint, you would do chondroitin, right? Because chondroitin, the bladder builder, the bladder rest, those are going to be the best at coating and protecting that tissue. And then on your skin on the outside, you're going to use Vulva Balm. Vulva Balm is an organic olive oil, avocado oil, and sea buckthorn oil that mimics normal mucus. And you can put this on your vulva every day. Okay. And let me open it up here. This is my personal, this is the one I use. Okay, I've had this now for 2 years. I still have half of it. It's $26. Smells fine. And it's just, oh, that was way too much. It's a very, very, very light oil. And you can put it down there. It's not a medicine. There's nothing in it that's going to irritate that skin. It literally is like a natural Vaseline. But the purpose of using it is when you protect that skin with an oil, urine can't reach the nerves in the skin and cause irritation. Darla says, I'm 65. Darla, so am I. Honey, you are in estrogen atrophy. Are you still having your period? When did your period stop? As soon as your period stopped, you started going into atrophy. And at the age of 65, unless you're just rare and still having a period, you have to be in atrophy. And the problem is atrophy presents directly in the urinary tract. This is called the genitourinary syndrome of menopause. Your bladder wall needs estrogen to make that nice thick coating of mucus that protects it from urine. When you don't have the estrogen, your body can't make the mucus, which means your bladder's ability to defend itself is now compromised. So instead of having a really thick layer of mucus, you probably have a little tiny layer of mucus. And thus, that cup of coffee you used to be able to drink, your bladder can't defend itself from anymore. That lemonade, whatever. Estrogen atrophy is real. And it's not about the blood testing. It's about how your skin looks. And for those, no, we don't sell. Estrogen is a prescription only. We don't sell it. Nor should we sell it. I mean, you need to have a doctor look at your skin, preferably a gynecologist, because what they see will determine your dosage. Whether you're going to do it every day or every 2 times a week or 3 times a week. It's important to let somebody look at the health of your skin. But at the age of 65, come on. And the thing is, yeah, so your period stopped 15 years ago, like mine. Yeah, you're done. You're in atrophy. Yeah, maybe the problem is you were thinking oral estrogen, and this is not an estrogen pill. This is an estrogen cream that you use on your vulva at the entrance to your urethra and or in your vagina. Oral estrogen is certainly not supposed to be given to women over the age of 60 because it does present a greater risk of cancer. But topical estrogen creams are not associated with that risk to any great degree. And that is one reason why to remove the black box warning. Listen, the black box warning for estrogen was the result of one reporter grossly misinterpreting some research results that created this wide-scale panic about estrogen and cancer. And now everybody now recognizes that he got the math way, way, way wrong, and that the risk associated with it is much, much tinier. But that said, cancer I'm a breast cancer patient. Cancer is cancer. It's out there. We've all been exposed to carcinogens. Once you've been diagnosed with cancer, the last thing you want to do is increase the risk of it. I will admit that I should be using my estrogen 3 times a week. I'm only using it once a week. There is an irrational fear associated with cancer too that I certainly have. Jill said, I hit menopause at freaking 42 and went on hormone replacement for a long time until I had a blood clot. You would think your gynecologist would tell you stuff like that when they examine you. It's not like I haven't been every year, got a new doctor, and it's time for a new conversation. Jill, I've got a really good video on this on our website. And I'll play it at the end of the meeting. Noreen said, is organic coconut oil good? Yeah, it's fine. It's just messy as hell. The problem with coconut oil is it soaks through everything. And so I used coconut oil for a while, and then one day I came home and I was wearing a long sundress, and it looked like I peed my pants. And it was an oil stain from sitting that soaked through my underwear into my sundress. And I was like, oh, yeah, no, horrifyingly embarrassing. So this vulva balm is much better. It's just not as messy as coconut oil. Jill said, the doctor would not even do topical estrogen on me. Believe me, I asked. Maybe I need to go to another doctor because things change all the time. But I think after you go through it, you can't go back, can you? I think you have to have a conversation with another doctor and see what they have to say. I mean, blood clots are real, hun. And I mean, certainly oral estrogen is out for you, for sure. So the question is would a tiny amount of estrogen used at the entrance to your urethra increase your risk of blood clots? And in the end, that's a discussion you have to have with your doctor. It is not in my place to give you any medical advice about that at all. Darla said, I got Uvafem from the doctor. Is that what I'm talking about? You're the second person to ask me about Uvafem. That's a new product. I don't go to the gynecologist anymore. I have a young gynecologist now, and she annoys the heck out of me. Very entitled. Oh, Jill, I can't hurt that much. Honey, come on now. I've had vulvodynia since I was a teenager. You don't get to tell me that. Uvafem is a low-dose local estrogen medication used to treat menopausal symptoms like vaginal dryness, burning, and pain during intimacy. It is inserted directly into the vagina in a pre-filled applicator. So is it a pill or is it a cream? No, it's an insert. So it's a tablet. Okay. So, it's like Vagifem. It's a tablet. The pro of a tablet is that it's not messy, easy to use, easy to insert. The con of a tablet is that it doesn't let you put it where you might need it the most. And so, for example, a lot of patients use their estrogen, a pea-sized drop at the urethra, which is where I do it, or on their vulva. So, but you know what? Listen, if it works for you, it works for you. Power to you, girl. Darla says, what about testosterone? There are a lot of mixed opinions about estrogen and testosterone, and that's between you and your doctor. I honestly, I don't understand a lot of the new estrogen testosterone combinations that have been happening in the last 2 or 3 years. I haven't researched it, so I'm not the right person to ask that to. Noreen says, where can you buy if you want the vulva balm in the IC Network shop, which is, if you just go to icnetwork.org and click on shop, that will take you to it. Jill said, I've been feeling really good that I'm using Cymbalta for depression, and obviously it helped. I think the whole bladder situation, and I would do it again if it would get me where I am. Yeah, I mean, I respect that totally. She says, I'm 98% better and I can feel the difference. Now the depression thing is hopefully going to resolve itself. There are other things you can do to hopefully get off these meds when they no longer serve their purpose. Exactly. And as long as you're informed of that, you're good to go. you're good to go. I mean, your doctor gave you the prescription, you're using the prescription as they suggested, you're getting good results with that prescription. Fantastic. We have to learn from Elmeron. I mean, that's the heartbreaker. The heartbreaker in the IC world is that the medication that was prescribed to virtually every IC patient is now linked to blindness, and it took years for that to come out. And it's heartbreaking because now that we phenotype, we know that bladder therapies aren't going to help the great majority of people anyway. People were taking a medication that had no chance of helping them. If you were pelvic floor driven, if you were widespread pain driven, if you had Hunner's lesions, taking Pentosan would not have provided significant help. It just wouldn't have. And so that's a heartbreaker for me, in my opinion, is that some patients have been chasing the symptoms. I call this chasing the symptoms for 5, 10, 15, 20, 25 years, rather than focusing on the cause. And now that we are phenotyping, we're focusing on the cause. Now that we're phenotyping, we can find the right treatment for that patient's unique cause. And the role for Elmeron has now gotten much, much smaller. So the place where Elmeron, if it hadn't been linked to retinal disease, where it would have shined would have been estrogen atrophy, because it's a coating. But the risks versus benefits. The risks of Elmeron are significant now with the retinal disease and the inflammatory bowel disease. So that's a discussion you have to have with your doctor. But especially if you're getting older, the most important thing that you're going to need as you get older is your sight. So I personally think the risks are outweigh the benefits, but that's my opinion. Peggy says, have a peaceful night, Jill. Oh, you're welcome, Peggy. Thank you. Jill says, thank you so much for talking to us today. And to me in particular, you're doing oh, thank you, honey. I appreciate that. Jill says, I took Elmeron and finally only took one a day. Thank goodness my retinal specialist that I go to twice a year is still proclaiming that I don't have retinal poisoning. That's what he calls it. You don't do the drug anymore. It's not worth your eyesight. I don't care. You just never know who it's going to make blind. Well, we do know what the research shows, that if you were exposed to 500 grams or less, you have a 12% increased risk of retinal disease. If you're exposed to 1,000 grams, you have 30% chance of retinal disease. If you're exposed to more than 1,500, you have a 42% risk of retinal disease. And Jill, I'm really glad your eyes are good. That's great. Keep getting them tested. But the other thing, when you got your colonoscopy, look for polyps, because that's the other thing we're seeing now is uncontrolled polyp growth in the bowel. Veronica says, I sting and burn in the urethra, pains in my stomach all the time. Anytime any urine goes into my bladder. I've been like this for 8 years. Nothing helped. Tried Elmeron installations, pregabalin, you name it. All right. So, Veronica, urethral pain is actually not a consistent symptom of IC. So when a patient has a lot of urethral symptoms, we're going to look for other common factors. And I have an article on the IC Network website, the 7 causes of urethral pain. So let's go through those really quickly. So cause number 1 for urethral pain is estrogen atrophy. The urethra is the canary in the coal mine when it comes to estrogen levels dropping, and it's often the first part of the urinary tract to get very, very dry and very, very irritated. It happened to me when I was 51. And it feels like there's a drop of urine in your urethra that will not come out. I had that symptom for about 3 months. And I mean, listen, my ICL self-help skills are obviously really good. I mean, this is my job. This is what I do. And yet I threw everything I knew at this urethral pain. Nothing worked. It was getting worse. I threw myself on the mercy of my urologist. Please help me understand this urethral pain. What is it? And he took one look and he goes, didn't you use the estrogen cream I prescribed for you last year? And I very meekly said, no. He said, why? And I said, because under my brain, I'm 25 years old and I can't possibly have an age-related issue. And he laughed. And he goes, yeah, no, I saw this happening, honey. You got atrophy in your urethra. And he re-prescribed it. And when I used my estrogen for a couple of weeks, it went away. If I forget to use my estrogen, it comes right back. Okay, so estrogen atrophy, quality and health of the skin is number one. The second thing we're going to look at is tight pelvic floor muscles. We call this a urethral stricture. So if it feels like you're trying to pee through a needle, if you don't have a good healthy stream, if you're stopping and starting, your levator ani pelvic floor muscles wrap around your urethra, just like they wrap around your vagina and wrap around your rectum. You basically have a hole for all three. And when they get tight, what do? They squeeze. So if your urethra is being squeezed, that's going to cause urethral pain and it's going to make it hard to pee. And God forbid the doctor want to do urethral dilations like they used to do 20, 30 years ago. I had a bunch of those done. Not fun. Today we go, gee, why is the urethra so narrow and tight? The answer is, oh, what's going on with her pelvic floor? Could her levator ani muscles be tight? A third thing that we're going to look at is skin sensitivity. It's very common for the urethra to get irritated after being exposed to certain chemicals. So it could be fabric softener. I don't use any fabric softener. It could be laundry detergent. Man, if I put on a pair of underwear washing Tide or Cheer, I will have urethral burning in about 10 minutes. My skin is that sensitive. It could be a douche. It could be a menstrual pad. It could be a mini pad. Any of those chemicals, especially if you're in atrophy, are going to irritate that skin and the nerve. So that's something we're going to look at. We want to look at the periurethral gland. So your urethra is about the size of your little finger. Halfway up your urethra, on the outside of the urethra, is what looks like a sea sponge. It's actually a prostate gland. Women have a prostate gland. It's called a homologue to the male prostate. When they look at it under a microscope, it looks exactly like male prostate tissue. So we have a prostate too. It's much smaller, but it's there. And just like the male prostate, the female prostate can get easily blocked because the drainage ducts are microscopic. And so what happens is this gland becomes basically a very deep pimple. And it's like the size of a green bean, a green pea, like a large green pea, maybe half the size of a kidney bean. So it's very easy to tell if you've got an infected periurethral gland. You just wash your hands really well, use a little KY, stick it up your vagina, and you're going to palpate along the front side of your vagina just about an inch. That's all, because remember, your urethra is only this long, the gland is about halfway. So all you got to do is put your finger in about this far, rub the front side of your vagina, and if you feel a deep pimple, you have an infected periurethral gland. It's rare in women, but I've worked with several women that have had this. And what's so interesting is when they tried it, draining it is a bitch. It's very hard to drain because they have to put something up your urethra and something in your vagina and basically squeeze it, basically pop the pimple, for lack of a better term, try to express the pus and whatever it is. And when they look at the bacteria, it's not just one bacteria. Man, there is a ton of different bacteria living in that periurethral gland. Periurethral gland infections are certainly possible. So, if you want to give me a phone call this week, I'd be happy to talk with you and see if we can figure this out. I might be able to give you some new questions to ask to your doctor. What I don't understand are the pains in your stomach. I want to know, is that in your stomach or in your bowel? So give me a phone call, hun. My phone number is right at the top of our website, 800-928-7496, or if I move the mic away, there it is. Okay. Darla says, haven't taken mine yet. I'm afraid of a flare. Why are so many doctors still pushing Elmeron? I literally fought with my doctor about choosing not to take it. She laughed at me. Well, number one, it means that they haven't taken a class recently. They haven't read the guidelines recently, or they're treating IC out of an old textbook. But for a doctor to laugh when you said not to take it because you wanted to save your eyesight, man, that's like medical board complaint worthy. That's horrific. And it's very frustrating. It's very, very frustrating that we're seeing patients today still being prescribed it when so many patients are losing their eyesight and having to have their bowels removed. It's crazy. For anybody out there, if you've taken Elmeron and you've had any side effects, diarrhea, loose bowel, eye issues, anything, please Google MedWatch database. MedWatch is the way our government monitors adverse events, and I need you to file with the FDA what happened to you, because we need a lot more data if we're going to expand this black box warning, or better yet, have the FDA review the FDA approval. I'm not convinced that it should be on the market. I'm not. The hard thing is that we're the only ones providing support to these patients. We're the only ones providing support. The other group is not providing support, and they have nowhere to go. They are so enraged by what's happened to them. I mean, I get emails all the time now from patients who have either lost their bowel or they've lost their eyesight or close to losing both. And I just think that if doctors heard their stories, they would be a lot more cautious. And so we're working really hard to share those stories. And what we're doing now is trying to get more patients to file MedWatch reports. And we're doing a patient registry. I'm just waiting for Emory to give me the last edits for it, and then we'll launch it. Emory University. Noreen said, I've been blessed listening to you today as I feel less anxious about IC. Everything you talked. Oh, thank you, honey. You're welcome. I do my best, but remember, I'm not your doctor. I'm an educator. My job is to educate you, inform you, maybe open up some new doors, and then kick you in the tush and get you back to that doctor with some new questions. Kayleen said, you were talking about urethral pain when I had to leave, but I deal with clitoral and urethral pain sometimes when I pee. Yeah, but Kayleen, you're a pudendal neuralgia patient. You've got muscle squeezing nerves, so that makes sense. Jill said, is this why he keeps checking me? Because it's something that could happen in the future? Oh my gosh, now I have to try to remember how much I took, but I didn't take full doses for long. But I'm sure I did it for months, and I don't know what the starting dose was. But I said it was 6 pills a day. Okay, that's high, honey. The FDA approved dose for Elmeron was 3 pills a day. Each capsule is 100 milligrams. So you were taking 600 milligrams a day. So if you're taking 4 a day, that's 1 gram. So if you were taking 4 a day for 50 days or 500 days, then that dramatically increases your risk. You didn't overreact at all, honey. You have the right to be upset and angry about this. I'm upset and angry about it. Veronica says, after push urine out, you squeeze all the time. Okay, honey, that's bad. Listen, urination is about relaxation. Normally you sit on the toilet, a sphincter relaxes, a muscle relaxes, a sphincter opens, and you pee, and it's virtually instantaneous. If you're straining to push urine out, that's not normal. That means you got tight muscles. At a minimum, you need to have a pelvic floor assessment and figure out what's going on with your muscles, if anything. Now, listen, if your muscles are perfectly normal, then that means the nerves in your bladder aren't working well. But I bet you it's probably muscle driven. Have you had a pelvic floor assessment yet? Jill said, I hope that I can figure out what I really have, because now I'm wondering, I have those feelings like you're talking about, but it's not like I have to urinate. It's just a really irritating, aching, painful thing. And I don't even have to go urinate a lot like somebody else that has stuff like this. It just doesn't go away even after I urinate. And it doesn't feel like anything is stuck. It just hurts. Well, honey, call me. Call me this week and let's, I have a lot more questions that I can ask to try to see if we might open up another door for what could be causing some of that pain. Kayleen says, I keep forgetting to use the estrogen. It also gets caught under the hood and it hurts so bad. Well, Kayleen, maybe you could switch to Vagifem, switch to the pill that you use in your vagina. Then it wouldn't collect under the clitoral hood. Veronica says, this is so true. I hate underwear. I can hardly walk because of the pain, like a needle inside me. I sit on my side all the time. Veronica, honey, that's pudendal neuralgia. Listen, if you can't wear underwear, the nerves in your skin are incredibly sensitive. And that's either extreme vulvodynia, extreme estrogen atrophy, or it could be pudendal neuralgia. But if you can hardly walk because of the pain and it feels like a needle inside of me, girl, you got to call me. That's not IC. I'm telling you right now, that's not IC. IC patients like to wear underwear. Underwear doesn't hurt. Underwear hurts vulvodynia. Underwear hurts estrogen atrophy. And when we see people who have pain when they're walking, I guess what I would say is, if it's vulvar pain, like sometimes what happens is you get so dry from atrophy that as you walk, your vulva is hitting each other and that hurts. So there's a dry, uncomfortable feeling that happens when you walk, and it's very distinctive. You absolutely know what it is when it's happening, because normally your vulva is slippery, and when you walk, it just slides like this and you don't feel anything. But if it's not slippery and you walk, it's rough and uncomfortable. So concept number one is, could that be going on? But I see bladder wall pain doesn't cause pain when walking, because the bladder isn't influenced by walking so much. The pelvic floor muscles are greatly influenced by walking and exercising. So if the act of walking is influencing pelvic pain, that means a muscle that's moving is causing the pelvic pain, or a muscle that's tight is pulling against you trying to walk, or maybe you have scar tissue or something like that. Again, girl, you need a pelvic floor assessment. I mean, and then a needle, that just brings up more because that needle-like sensation, if that's in your urethra, that's exactly what a dry urethra feels like. It's a sharp needle-like sensation. I have had that many times. But if that needle is somewhere else, if that needle is in your vagina or that needle is by your rectum, I'm thinking pudendal neuralgia. Sherry said, you actually sound better when you move the mic away. Okay. Remind me of that next time. Thank you for the stars, the 99 stars, Veronica. Thank you. Darla said, do I take my estrogen daily? Absolutely not. I don't. Listen, if I were in a sexual relationship, I probably would use it more frequently, but I'm not. And as I've said earlier, I just want to slug anybody who wants to touch me right now. You know, because I've just got so much post-op pain from my mastectomy. You can see the incision right there. You know, I have a neuropathy across my chest. And so it's like I have barbed wire across my chest on some days. It was like that this morning. And so I just... I just am like in a, as I say to everybody, it's like I'm just a bear in a cave right now, licking my wounds. I'm coming out a lot more than I used to, but you know, I'm in a keep away, you know, don't touch me mode. I never felt that way with my pelvic. No, I take that back. I did feel that way with my pelvic pain when it was bad. I don't really have icy pain anymore. I mean, when my pelvic floor gets tight every now and then. And I will feel that when I'm walking. And that's when I know I have to use my wand and get in there and relax it, which I probably need to do. All right, hold on. I'm coming back to YouTube here. Jennifer says, one last question. My pelvic floor is so painful at the moment. I'm having problem peeing. Was this close to going to the ER because I can't pee? It takes special breathing without emptying. So you could ask for a muscle relaxant, like a vaginal Valium suppository, Flexeril, or baclofen. Baclofen is a skeletal muscle relaxant that is not sedating. You can take it during the day. You can drive with it. It's good that you're breathing, which is good. My pain is so bad with pelvic floor, I can't bend over and I scream. I feel like I'm completely debilitated and you're in fight or flight mode. I'm seeing a pain clinic and a pelvic floor physical therapist every week. Okay, so Jennifer, this is what I want you to ask your physical therapist, and that is, are my muscles responding to therapy or are they always locking back down into tension? Because if your muscles are always tight, no matter what they do, we have to figure that out. And that's when we take a step back from muscles and we start looking at bones and joints and the tailbone and the hip bone and the SI joint, things like that. But for many patients, tight pelvic floor muscles come from how you walk. If you have an ankle that rolls in, if you have an ankle that rolls out, if you've got Morton's toe, if you're not walking normally, if you're limping, anything at all like that, if you've got plantar fasciitis, if you've got shin splints, those all point to issues with how your foot is hitting the ground. And unfortunately, any missteps, all of those forces are redirected back up your leg into your pelvic cavity where they tighten muscles. So if you have one leg longer than the other, then your pelvis is tilted to one side. That also is going to cause long-term chronic muscle tension. So ask the physical therapist, are my muscles responding or am I always locking back down into tension? Jill says, for the bowel disease, do I now go to a GI doc? I already have IBS and that was before Elmeron. Do I need to go get a colonoscopy to make sure that my insides are okay? I'm not sure. I'm not due. I will, though, if I need to make sure I'm okay. A gastroenterologist. You would go to a gastroenterologist and you would tell them that you have been taking Elmeron and that you want to verify if you're having any bowel issues from the Elmeron, like polyposis. Veronica says, thank you so much. You've been so helpful. I've learned more from you tonight than I have from my urologist in years. Veronica, true story. I had one of my clients bedbound for a decade. All of her 20s, she was in bed. Couldn't work, couldn't go to college, couldn't date, totally in bed. Diagnosed with IC, did all the IC therapies, nothing worked. You know what? I'm going to shut down YouTube because I think we're done with YouTube. So I'm going to, bye YouTube. I'll see you guys later. All right.